All right, guys. Good evening. Hi. Right. How was my OPD? My OPD was good. A bit weird, but good. No, when Americans make the guidelines of disclosure of information, what information can you give to the family members? They don't really take Indian scenarios in consideration. Today, I had a patient, and he was a patient with erectile disorder, and he was accompanied by his mother. He entered the OPD with his mother, and he was telling me the history. And I mean, if the patient is comfortable, I was discussing, and then he said, "Okay, sir, now I'll go outside, and you talk to mother." In rest of the world, the opposite happens. The family member goes outside, and the patient talks to you in private. But in India, the patient goes outside, and the patient with sexual disorder and asks his mother to talk about him. I was just thinking that ये सब अमेरिका के चोचले हिप्पा विप्पा सब गायब है, यहाँ पे कुछ और ही होता है, राइट? चलो, so what did the mom say? Mom asked the billion-dollar question: can we get him married? Hindustan में this is the question that they ask. All right, what did I reply? Now I'm not going to tell you that. What do you think? Whether the guy had psychogenic ED, nothing serious, he would get treated. All right, chalo, can you guys see the screen? And in such cases, the practical solution is, I mean, this is what I would say to a person who asks me this question. Let's see, go for a love marriage and then ensure that you have engaged before going for the marriage, because don't spoil the life of a girl first of all in case there is some problem, and secondly, don't get yourself into legal trouble, because such cases nowadays end up inevitably in the court. So Banerjee is asking, why did you leave USA, sir? I did not leave USA. I went to US. I stayed there for 6 months. I did not like it over there, and it came back. And I think it was a very good decision. हरीश कह रहे हैं, सर घर वाले नहीं मानते लव मैरिज के लिए. हरीश, आर यू श्योर? ऐसा तो नहीं लड़की नहीं मान रही लव मैरिज के लिए और तुम घर वालों का नाम ले रहे हो? हाँ, ऑलराइट. चलो चलो पढ़ाई कर लो. मधुमिता इज स्टिल आस्किंग मिलन बाय इफेक्ट. मधुमिता बेटा खुद से पढ़ लो. एक क्वेश्चन तो कब से कल से पूछ रही है. सो लेट अस टॉक अबाउट कैनबिस. Now, cannabis is the most commonly used illegal drug in India and world. Some countries is making it legal, but for majority of the countries, it remains illegal. Have I not shared the screen? The active ingredient of cannabis is delta THC, tetrahydrocannabinol. And a lot of people nowadays talk about that cannabis has some good properties also, and we can remove the THC and use the good component, which is not habit forming or which does not have dependence potential. So I was talking to one of DMs in addiction medicine about the same, and their viewpoint was very clear that it is almost impossible to separate out the different chemicals. So even if there are certain chemicals in cannabis which are not as harmful, it is almost impossible to separate them out. So there's no point talking about these things until unless we have clear distinction. Anyways, the street name of cannabis, you have heard of these joints, marijuana. The pronunciation is marijuana. Don't call it marijuana. Does not sound good. Marijuana, grass, pot, weed, all of these things you have heard of, right? Now, when somebody takes cannabis, why does anyone take cannabis? For this only, right? Humans can do anything to feel euphoria. So, euphoria. So, people feel happy, and then they say that the time gets slowed down. They feel as if the time has slowed down, everything is happening in slow motion. Some of them say that they feel as if they are flying in the air. Reddening of the eyes because of the dilatation of conjunctival vessels. Reddening of the eyes is what gives away the fact that somebody is high with cannabis. The family members identify by reddening of the eyes because cannabis causes conjunctival vessels dilatation. Appetite increases, also called as munchies. And I tell this story. I had a driver, and Some of the older students know this story. I had a driver, and I think 2 years back it was my birthday. So clinic staff had arranged the cake and all. So after cutting cake, the remaining cake was given to me, and I got outside the clinic and looked at my driver, and my driver looked high. And then I looked at his eyes; it was red. So I understood that he took cannabis. I got a bit angry over him, and then I told him that, okay, you sit at the back, I will drive the car. And I also kept the cake at the back seat. And after 5 minutes while driving, I looked back, and my driver was eating the cake while I was driving the car. And then I realized that this increased appetite that I teach for so many years is actually significantly increased appetite, because he was having cake nicely, did not worry about a thing. So the appetite really gets increased, right? And there can be dryness of mouth. Along with this, cannabis can cause depersonalization, derealization. In the chapter 1, we talked about reflex hallucinations, and we said that reflex hallucinations are caused by cannabis and LSD. So the same reflex hallucinations we are talking about here. What is bad trip? Bad trip, or as they call it, BT. So in bad trip, what happens is somebody took cannabis hoping that there will be euphoria, but say they start having illusions, hallucinations, and they get frightened. They get scared that maybe I'm going mad. So it's an unpleasant response, unpleasant reaction in which the patient gets frightened after taking cannabis. So it's called as bad trip. This is unpleasant. Withdrawal symptoms of cannabis, please put a star on irritability. It has been asked multiple times. And it can also lead to depressed mood and sleep disturbances. Just another thing in intoxication, write it. Dream-like state. Dream-like state. Right? Dream-like state. This has been asked in the exams. Dream-like state. So withdrawal is irritability, depressed mood, sleep disturbances, and intoxication is dream-like state. Okay? Cannabis related disorders. So one is flashback phenomena. So we talked about flashback where? We talked about flashback in the PTSD. So what happens is, say today somebody takes cannabis and he has all this experience, floating in the air, euphoria, all of that. Say 3 months from today, even without taking cannabis, he is having the same experience. That is called as flashback phenomena. Recurrence of experience. Recurrence of experience without any current use. Recurrence of experience without any current use. Today I did not even take cannabis, but I'm having the same experience that I had 3 months back. So today I'm having a flashback of what happened 3 months back. Okay? This is a big problem and a very unfortunate problem. I've seen so many medical students going through it. Amotivational syndrome, as the name suggests, loss of motivation for everything in life. You know, the way humans are wired, we feel pleasure only when we do something worth doing and which is slightly tougher. You must have experienced this. Say you are scrolling on Instagram for 2 hours. At the end of the 2 hours, are you feeling very happy? No. You usually feel either irritated or frustrated. On the other hand, if you study for 90 minutes on a stretch, at the end of the 90 minutes, you might be tired, but you get that feeling of satisfaction. Is it correct? On a particular day, so you say you study for 12 hours. When you go to bed after studying for 12 hours in the day, you carry that sense of satisfaction, right? This is how humans are wired, right? Now, this happens because the dopamine gets released. We know this is what we are supposed to do, and then our brain rewards us by releasing dopamine. Now comes cannabis or other drugs. They start hijacking the neurobiology. They start releasing the dopamine without doing anything. So at that time, you feel that euphoria. But now normal things cannot get the dopamine released. Now the normal things in life cannot get the dopamine released. That is why you start losing motivation with everything. And that is why people, once they start abusing substances, they keep going up, higher and higher. People start with alcohol, they may take cannabis, but after some time, even cannabis will not give you euphoria. So you have to go to opioids, then you have to inject yourself with opioids, then you have to combine cocaine and opioids. So it's a one-way street. Your brain needs bigger and bigger stimuli to get that dopamine. That is why people get stuck into this substance abuse issues. Okay. Somebody is asking evolutional versus amotivational. Pretty similar, right? Lack of drive and lack of motivation. What is run amok? You will talk about, you will study about it in forensic also. Excessive rage after cannabis use, in which the person can injure others indiscriminately. So the person gets into rage, and whosoever comes in front of him, he just thrashes the other person. This is run amok. Cannabis use can also cause psychosis. Using cannabis can lead to delusions, hallucinations. If that happens, it is called as cannabis-induced psychotic disorders. And the treatment, so we don't have any specific drug for cannabis. If the patient is having decreased sleep, we'll add a zolpidem. If the patient is having, say, anxiety symptoms, we'll add something for that. And psychotherapy. So unlike opioids and unlike alcohol, where we had specific drugs, here the treatment is primarily specific. Here the treatment is primarily symptomatic. We don't have any particular drug. Whatever symptom the patient is showing, we give the drug accordingly. Faraz is asking, please repeat cannabis-induced psychotic disorder. Faraz, if taking cannabis leads to development delusions or hallucinations, we call it cannabis-induced psychotic disorder. Okay? Usually there is no OD with cannabis, unlikely. Now I talk about hallucinogens. Now these are the hallucinogens. LSD is the prototype hallucinogen. Then we have mescaline, psilocybin derived from mushrooms. We have MDMA with the street name of ecstasy. Then you have PCP, also called as angel dust, and ketamine. Remember, we were talking about ketamine in the treatment of depression. This is why it is to be administered in doctor's office, because ketamine is also a drug of abuse. The name is hallucinogen. So what will it cause? It will cause illusions, it will cause hallucinations, and it can also cause DPDR. And bad trip may happen similar to cannabis. You are taking it to get high or feel good, but rather than that, you start hearing scary voices and you get frightened. That is called as BT, bad trip. Yes, PK Dhingra Saab, cannabis increases the risk of schizophrenia. Okay? Now let's talk about two specific hallucinogens, PCP and ketamine. This is a question from anesthesia. Both of them are considered as dissociative anesthetics, because when you give them, it appears as if the patient has dissociated, is not really responsive. Both of them are NMDA receptor antagonist. Now this is the thing. Phencyclidine and ketamine intoxication can look like schizophrenia. Why? The patient may become very aggressive, and the patient may start having hallucinations and even delusions. Say a patient comes to you, he is very aggressive, is talking to himself, saying that somebody is following me, somebody will kill me, and you think it's schizophrenia. You get the patient admitted, get the urine test done, and there you find ketamine or PCP, phencyclidine or phencyclidine. Another thing about phencyclidine is it can cause nystagmus. Nystagmus, vertical or horizontal nystagmus. Phencyclidine intoxication can present with nystagmus. Now, one of the interesting things about hallucinogens is that they do not cause any withdrawal symptoms. There are no withdrawal symptoms. They can also cause flashback phenomena, and treatment for them also is symptomatic and psychotherapy. Symptomatic and psychotherapy. Okay? Now we talk about cocaine. Cocaine is derived from the plant Erythroxylum coca. One of the most famous psychiatrists, Sigmund Freud, is believed to be addicted to cocaine for some time. In fact, Coca-Cola, the drink Coca-Cola, Coke, used to have small amounts of cocaine in the early 20th century, till like 1905 or 1907. It used to have small amounts of cocaine. Then it was stopped. So when cocaine was synthesized, it was being prepared as a local anesthetic. Look at the name also. Cocaine is same as lignocaine, lidocaine, prilocaine, right? Why? Because it does block sodium fast channel. It does block fast sodium channels. Anything which blocks fast sodium channels will interfere with the nerve transmission and can be used as an anesthetic agent. Another thing about cocaine is it's a strong vasoconstrictor. It's a strong vasoconstrictor. So if you have an anesthetic agent which is vasoconstricting and has properties of a local anesthetic drug, it becomes very useful in surgeries of ENT. Why? The ENT area is very vascular and you want to give something that will cause vasoconstriction so that the bleeding becomes lesser. But of course, we can't use it because of the dependence potential. But it has been used in the ENT surgeries. Now, how does cocaine work? Cocaine blocks the reuptake of dopamine and norepinephrine. It blocks the reuptake of dopamine and norepinephrine. Now, if you're blocking the reuptake of norepinephrine, and if the levels of norepinephrine increase, it leads to vasoconstriction, of course. And if the vasoconstriction happens in the coronary arteries, it can even lead to myocardial infarction. So that is why cocaine use can lead to heart attack, myocardial infarction. Of course, it can cause hypertension, but it can cause myocardial infarction. How is cocaine used? Cocaine is snorted. You must have seen it. It's a powder and people make a roll and then they close one nostril and they snort it. So it is absorbed through the nasal mucosa. So if it is going to nasal mucosa repeatedly, it causes vasoconstriction of nasal mucosa repeatedly. Vasoconstriction leads to ischemia, which can lead to nasal septal perforation. So it can lead to nasal septal perforation. It can lead to nasal septal perforation. And if the levels of dopamine or norepinephrine become too high, it can lead to seizures. It can lead to seizures. Smoking cocaine can cause jet black pigmentation of tongue, and it has been a MCQ that keeps repeating in the exams. So people can snort cocaine or they can smoke cocaine, called as freebasing. And rarely it can also be used in IV or subcutaneous routes. It can be used through IV or SC route, subcutaneous route. Now, cocaine intoxication will present with all the sympathetic symptoms. Why? It is increasing the levels of norepinephrine. And cocaine anyways is a stimulant. People use cocaine because they want to get energetic. It stimulates the brain. So, of course, euphoria is here. But all the sympathetic symptoms, your tachycardia, your palpitations, your hypertension, your sweating, your mydriasis, all of them are there. So because cocaine is increasing the levels of norepinephrine, but cocaine is also increasing the levels of dopamine. And what is the result of a hyperdopaminergic state? Remember in schizophrenia, we said that positive symptoms are caused by a hyperdopaminergic state in mesolimbic tract. So similarly, if the dopamine levels increase, it can lead to delusions and hallucinations. It can lead to delusions and auditory hallucinations. Delusions and auditory hallucinations. Vasundhara is asking, sir, what is freebasing? Smoking a form of cocaine, a very pure form of cocaine is called as freebasing. Freebasing. And then our pet question, that cocaine use can lead to feeling that there are insects crawling under the skin, called as cocaine bugs, which are a kind of tactile hallucinations, also called as Magnan phenomena. The examiner may give this question to you. A young patient comes to your emergency and there are scratches on the arms and forearms. Which drug is he likely to be abusing? So he takes cocaine, that which causes hallucinations, he scratches, and this is why the presentation. These are called as cocaine bugs or Magnan phenomena. ठीक है? Midday module में था question? Good. So when you solve midday module, you will find the questions to be much tougher than the questions that you see in the late night PYQs. And that's perfectly fine. Midday module is supposed to be tougher, right? So don't get too worried. And that is likely to happen in almost all the subjects. And you will see long questions, no, USMLE type long questions. Vikas is saying, sir, how can students score 190 out of 200? देखो ऐसा है ना, the toppers tend to do things like this. They tend to outperform everybody else. So there would be some students who keep on performing very well. So you don't have to get discouraged by that, right? Don't look at the marks scored by only toppers. You have to ensure that in this long journey, you persevere. You have to continue giving tests. Don't judge your scores in the every test. If you can do that, you will be at a lot of advantage. A lot of people stop taking tests, and it is going to happen to some of you as well. Because when they don't do so well in the test, they get demotivated. But if you can somehow tell yourself that test is just to increase my knowledge, not to check my knowledge, you immediately develop a very big advantage point over the other preparants, right? So do that. Now we talk about amphetamines, which are also stimulants like cocaine. So we have some drugs like dextroamphetamine, methamphetamine, methylphenidate is also an amphetamine-like compound, and they are stimulants. They are used for euphoria and enhanced performance. Okay. Finally, tobacco. Tobacco is the most commonly abused substance in India. BD is the most common form, followed by use of cigarettes. And we all know that stimulant in cigarette or tobacco is nicotine. The cardiovascular diseases are caused by both nicotine and carbon monoxide, which is there in the smoke that gets generated when the tobacco leaf burns. Withdrawal symptoms of tobacco are important, and they start within 2 hours of stopping smoking. Withdrawal, that is why people become chain smoker. Within hours, you start having withdrawal symptoms, and they peak in 24 to 48 hours. You must have seen people who smoke, when they don't get cigarettes, they become very irritable. They say that I cannot study. I am not able to study. And they become restless. They go from room to room asking for cigarettes. Now, when you smoke, cigarette is a stimulant, it will cause tachycardia. When you smoke, it will cause tachycardia. So in withdrawal, what will we see? Bradycardia. Bradycardia. Why do people smoke? To feel more active, alert. So in withdrawal, what will happen? They will feel drowsy. They will feel drowsy, but can't fall asleep. They feel tired, but can't fall asleep. In withdrawal, the appetite also increases. In withdrawal, appetite also increases and weight gain happens. Again, when you smoke, you tend to feel alert. In withdrawal, what will happen? You will feel depressed. You will feel depressed. And constipation is one of the important withdrawal symptoms. When we try to help people quit smoking, they're able to quit other cigarettes, but the cigarette they smoke right after getting up, before they go to washroom, that is the most toughest for them to quit. They say they get constipated if they don't smoke, because constipation is one of the withdrawal symptom. If someone wants to quit, they just have to persevere for 24 to 48 hours. No. Withdrawal symptoms peak at 24 to 48 hours, but they may continue for 1 week, 2 weeks. But yes, the toughest time is 24 to 48 hours. After that, it tends to become slightly easier. Paradoxical insomnia explains her. So basically, the person is feeling drowsy, is feeling sleepy, but can't fall asleep. Is feeling sleepy, but the sleep evades him. नींद आ भी रही है, but सो नहीं पा रहे हो. Treatment. So one way of treatment is using nicotine replacement therapy. We say, okay, you want nicotine, na? rather than taking nicotine in the cigarette, take gums or take nicotine patches. Now we even have nicotine lozenges, toffee type, or nicotine inhalers. So all these things have come up. For nicotine gums, we say that 15 minutes before and after taking gum, don't eat or drink. Especially no acidic drinks like tea. 15 मिनट्स ही है ना, देखना एक बार नोट्स में. इज इट 15 मिनट्स ओनली? 15 मिनट्स लिखा है ना, ठीक है. So basically what happens when you chew nicotine gum, say you are chewing nicotine gum, the nicotine from the gum gets released and it dissolves in the saliva and it gets absorbed through the oral mucosa. Now after taking the nicotine gum, if you take tea, the absorption of nicotine would get impaired, or the nicotine would not get absorbed. Also, when you take nicotine gum, you chew it and then you have to keep the saliva in the mouth only. If you swallow it, first of all, you will have GERD, reflux, and secondly, it would not be absorbed. So you have to chew it. I mean, what we tell patients is you chew the gum and then you park the gum on one side and you keep the saliva in the mouth. When the taste of the gum stops, then you again chew the gum and this time take it to the other side, again park it, then again. So this is how you do it, because when you chew it, the nicotine gets released, gets absorbed in the saliva, gets dissolved in the saliva and then gets absorbed through the oral mucosa. But now we have very effective medication in the form of varenicline. It's one of the best medications, the drug of choice for tobacco cessation. How does it work? It's a partial agonist. At alpha 4, beta 2 and alpha 7 nicotinic acetylcholine receptor. Alpha 4, beta 2 and alpha 7 nicotinic acetylcholine receptor. So basically when you smoke, the nicotine goes and gets attached to this receptor that gives you that high. When you are taking varenicline, the receptors are already blocked. So when you smoke, you don't get that high. Also, when you smoke, the nicotine gets attached to this receptor, and when it detaches, you start feeling withdrawal symptom. Now varenicline is attached already to this receptor, so no high, and because it remains attached to the receptor, there is no withdrawal symptom either. That is why it is so effective in treating tobacco cessation. So there is no high and there are no craving or withdrawal symptom. The side effects include nausea, insomnia. Initially, when varenicline was introduced, one of the warnings was that it may increase suicidal thoughts, but later on, it was withdrawn. It was found that there is no increase in suicidal thoughts. Later on, it was withdrawn. This warning was withdrawn. Later on, this warning was withdrawn. Initially, they thought that it may increase suicidal thoughts, but later on, it was withdrawn. It is usually used for 6 months. We give it for 3 months, and if the patient achieves abstinence, we continue it for 3 more months. The best treatment for smoking is varenicline only. Varenicline. The other drug that can be used is bupropion. Now, lastly, we talk about the trans-theoretical model of change. Whenever we want to change any habit, or any habit change goes through certain steps. Any habit change goes through certain steps. These steps are called as, or this theory that a change happens through certain steps is called as trans-theoretical model of change. So say somebody wants to quit alcohol. quitting of alcohol will happen in certain stages. The first stage is called as pre-contemplation, when the person is not even considering it. In contemplate means thinking, pre means before thinking. So in pre-contemplation, the person does not even realize that there is a problem, does not even think about it. Then comes the contemplation stage, when the person starts thinking, should I quit drinking? And he starts looking at the pros and cons. He thinks that when I drink alcohol, I enjoy, I sit with my friends, we have fun. But at the same time, every time I drink alcohol, I have fights at home and there's a lot of money loss. And last month I got into a fight. So he starts weighing the options. Is it good? Is it bad? This is called as contemplation. Then the person takes a decision that, okay, I have to quit. And he starts preparing. He says that, okay, I have to leave alcohol. This Saturday, I'll go and see a doctor and will start the treatment. So he takes a decision and starts planning. Then on Saturday, he quits alcohol and starts the medication. This is called as the action stage. Now he quits and starts taking medications, and he also decides that I would not hang out with those friends with whom I used to drink, because they would again make me drink. And finally, maintenance stage, where the person remains abstinent. Abstinent means away from alcohol. Patient remains abstinent. He may remain abstinent, or he may relapse to one of these stages again, or he may go back to one of these stages and may again continue. Okay? So this is substance use disorder, trans-theoretical model of change. Now we'll talk about neurocognitive disorder. Previous slide, ये लो, देख लो. Abstinence means not using the substance. Maintenance stage मतलब the person remains abstinent means is not using the substance. He has quit alcohol and he remains away from alcohol. If a relapse occurs, the patient can start from any of the stages. He may go back to pre-contemplation, he may go to contemplation, he may go to preparation, he may go to any stage. Now we talk about neurocognitive disorders. There are two, delirium and dementia. I will be covering delirium. Dr. Dilip covers dementia. So we have already talked about delirium. We have already talked about delirium, where when we were discussing delirium tremens, right? And I told you there are three main symptoms. So you'll see the same symptoms again. Delirium, it is the most common neurocognitive disorder with an acute onset. With an acute onset. And usually seen in older age. More commonly seen in older age. The older name for neurocognitive disorders was organic mental disorders. Or organic brain disorders. ठीक है? So in delirium tremens, we talked about three symptoms: disturbance of consciousness, which is here; disorientation to time, place, and person, which is here; and perceptual disturbances, mostly visual hallucinations, which is here. So the symptoms of delirium tremens are same as delirium. In fact, delirium tremens is a type of delirium caused by alcohol withdrawal. The patient may also present with transient delusions. And of course, if the consciousness is impaired, if the orientation is impaired, it is quite likely that the attention would also be impaired. The patient's attention is impaired. That is why if you are conversing with a patient who has delirium, you have to speak very slowly and you have to speak loud, because the attention is not good. So if you want to communicate, speak loud and slowly and clearly. Dr. Somnath is saying, sorry for saying this, sir, and I know you are the teacher, but can we pick up the pace little bit? We have around 100 slides remaining. Right. Memory disturbance. Memory disturbance. In memory disturbance, the disturbance of recent and immediate memory is more, and remote memory is usually intact. Remote memory is usually intact. So more disturbance of recent and immediate, and remote memory is intact. Okay? Now, delirium can present either with agitation. So these patients would be very agitated. They are lying on the bed and they are removing, they are trying to take out the drapes, moving here and there, tossing and turning on the bed. So these patients are easily catch attention of the medical staff. Hypoactive delirium is more dangerous because it does not come to attention. Imagine there is a medicine ward with 50 patients and one person is quietly lying, not saying anything. He is confused, he is having hallucination, but creating no ruckus. It is likely to be missed. So hypoactive delirium tends to get missed. And there can be autonomic disturbances also. Sleep-wake cycle disturbance. In its extreme form, the patient sleeps at daytime and wakes up at night, called as sleep-wake cycle reversal. Sleep-wake cycle reversal. Sundowning. What is sundowning? As the sun goes down, the symptoms increase. Worsening of symptoms. Worsening of symptoms in evening. What happens? As the evening approaches, as the visual input decreases, the patient becomes even more confused. So this sundowning is not only seen in delirium, it can be seen in dementia also. It is a feature of both delirium and dementia. Worsening of symptoms in the evening. There is something called as flocculations or carphologia, aimless speaking behavior. So basically what happens is, in delirium, patients may have tactile hallucinations. And sometimes they are lying on the bed and they do this as if they're trying to pick something. This is called as flocculations or carphologia, aimless picking behavior. What is occupational delirium? Patient behaves as if he is at work. So patient is lying on the bed, but he keeps on behaving as if he is at the work. Say the patient was a bus conductor. On the bed he is shouting that 10 rupee ticket, 20 rupee ticket, next step coming, next stop coming, next stop coming, right? Or say the patient is a medical student. He is on the bed and is shouting, send PDF, annotated PDF, Telegram group link, teach fast, teach slow, right? All of this. So things that you do usually in your life, you keep doing the same things. This is called as occupational delirium. Remember this, sudden onset and fluctuating course. This is important. Delirium always has a sudden onset and the course tends to fluctuate. Which means in the morning, the symptoms may be lesser. When all the senior doctors are there, the consultants are there, the symptoms are less. In the evening and late evening, when the deadly interns are roaming around in the hospital, at that time symptoms worsen and the interns don't even care. So the course fluctuates. It fluctuates a lot, right? So sudden onset and fluctuating course. Okay? Now there are hundreds of things that can cause delirium. Any serious medical disorder or surgical disorder can present with delirium, right? So things like hip fracture, burns, MI, post-surgery, infections, any of these can present with delirium. Any serious medical or surgical disorder can present with delirium. Alcohol delirium is called as delirium tremens. Even sedatives withdrawal can present with delirium. Remember, I talked about one particular type of drug which can lead to delirium. Which can lead to delirium. Which one was it? Which drugs can lead to delirium? Anticholinergic drugs. I told you that anticholinergic drugs are especially likely to cause delirium. And then if we can also have sensory deprivation leading to delirium. There's a delirium called as black patch delirium. Earlier, after cataract surgery, sometimes they used to put black patches on both the eyes. If you're putting both black patches, no sensory information is coming in, and that lack of sensory information can cause delirium. That lack of sensory information can cause delirium. ठीक है? That lack of sensory information can cause delirium. So the neurotransmitter involved is acetylcholine. The neurotransmitter involved is acetylcholine. And I talked about this. There is a system called as reticular activating system. This is a system that keeps you awake. This is a system that keeps you awake. And when this pathway gets impaired, delirium symptoms may develop. We talked about this also, that MMSC is used as a screening tool for delirium and dementia. MMSC and also MSC, put a star on this. CAM, confusional assessment method. CAM or confusional assessment method is often used by the ICU staff especially to identify the patients with delirium. So confusional assessment method is used by the ICU staff to identify the patients with delirium. To identify the patients with delirium. ठीक है? To identify the patients with delirium. If you do investigations, there is no clear-cut investigation on the basis of which you can make a diagnosis. So diagnosis of delirium is clinical. What is the meaning of this line? It means that you make the diagnosis of delirium on the basis of clinical signs and symptoms. You make the diagnosis of delirium on the basis of clinical signs and symptoms. But if somebody asks you the investigation finding, on EEG you can find generalized slowing. On EEG you can find generalized slowing, except in alcohol and sedative withdrawal delirium, in which you can see the fast activity. In other deliriums you can find generalized slowing, but only in alcohol and sedative withdrawal. Rather than slow activity, you will find fast activity, low voltage, fast activity. The typical case that comes in the exam is like this. A 40-year-old male fell from the bed and developed hip joint dislocation. He was admitted to the hospital and he was operated upon. He was recovering well when suddenly he appeared confused and agitated. He said that he is in a jail while he was in the ward. And he also said that he can see small insects coming from all the sides and approaching him. What is the likely diagnosis? Batao. What is the likely diagnosis? Delirium. Sometimes you answer it as schizophrenia, thinking that he is having hallucinations and delusions. But the moment you see he appears confused, confusion will never be seen in schizophrenia. Confusion or disturbance of consciousness is a feature of delirium. Delirium. So what is the treatment? Treat the cause. Whatever is causing delirium, treat it. Treat the cause, right? You can use benzodiazepines if the patient has delirium tremens. And if you are not given any cause, if you are not given any cause and simply asked to choose a drug, then go for haloperidol, antipsychotics haloperidol. Best answer is treat the cause. If hypoxia is leading to delirium, treat hypoxia. If multiple medications are leading to delirium, stop the medication. If delirium tremens is causing delirium, use benzodiazepine. But if they do not give you any cause and ask you which drug to use, then choose haloperidol. Haloperidol. Chalo. So we'll remember this table that helps us differentiate delirium from dementia. Delirium always has a sudden onset, whereas dementia develops gradually, insidious onset. In delirium, disturbance of consciousness is the primary symptom. Main symptom is this. In dementia, you never have a disturbance of consciousness. And in delirium, the course fluctuates. Whereas in dementia, it gradually worsens. Okay? Now we'll talk about personality disorders. So whenever we have to describe, Hussain is saying, what does disturbance of consciousness mean? Hussain, it means that you are not completely alert. You're not awake or alert, right? Your alertness is lower, at a lower level. Okay? Previous slide, please. Previous slide, theory. Insidious means gradually, yes. Dr. Lekela is asking the same question he or she was asking yesterday. Class till when? अभी तो start हुई है. It has just started. हाँ, सुशांत ने अच्छा आंसर दिया till last page. चलें आगे. Let's talk about personality disorders now. So before describing personality disorders, we have to understand what personality is, right? So when you have to describe the personality of an individual, you describe it according to 5 traits. So what are 5 personality traits? The first one is the mnemonic is ocean. And the first trait is openness to experience. Also called as novelty seeking or sensation seeking. Openness to experience, also called as novelty seeking or sensation seeking. It means how much as an individual are you looking for new experiences in your life? The people who have very high openness to experience, they do things like they keep on doing new things like bungee jumping or cave exploration or scuba diving, right? So this is suggestive of high openness to experience. You want to experience new things. The second trait is called as conscientiousness. What is conscientiousness? How dutiful you are. How much you follow rules. So conscience or conscience, it is that internal voice of doing the right thing. Is that internal voice strong that do the right thing or not? That is your conscientiousness. And then we have extraversion. How extrovert are you? Who are extroverts? People who are comfortable with new people. They become comfortable with other people very easily. Who are introverts? Who are comfortable in their close groups. They don't really like talking to people much. Agreeableness. How cooperative you are. How cooperative are you? Do you easily agree to others or not? And then N stands for neuroticism. Tendency to experience negative emotions. So some people tend to experience negative emotions very easily. On small issues, they will get very upset. Or on small issues, they will get very angry, irritated. So that is their neuroticism. So we have 5 traits: OCEAN, ocean. Ocean. Okay? Now, if your personality is such that it is causing impairment in life or distress in your life, in that case, we say that you have a personality disorder. So, personality disorders are egosyntonic. We talked about the term ego dystonic when we were discussing OCD. In OCD, we said that when the person is having obsessions, he does not agree to it. When he is doing compulsions, he does not agree to it. Personality disorder, on the other hand, is egosyntonic, which means agreeable to self. Whatever kind of person you are, you think that that is the right thing. You think that is the right thing. For example, say you have very high openness to experience. You jump from here, there, you go scuba diving, you do snorkeling, you do bungee jumping. And if somebody tells you that you are living a very dangerous life, you will say, this is how life should be lived. Why should I live a boring life? I want to have all the experiences. So whatever you are, the way you are, you usually like it that way. This is the meaning of egosyntonic, that you agree to whatever you do. Now, personality disorders are divided by DSM into 3 clusters. So we have cluster A personality disorder, cluster B personality disorder, and cluster C personality disorder. Let us talk about the 3. So cluster A PD, it is considered to be on a schizophrenia continuum. What does it mean? Say there is this line, this is normal and this is schizophrenia. So these people who have cluster APD, they are considered to be somewhere here. They have certain characteristics which are not normal, but they are not having symptoms like schizophrenia. It's a continuum. ठीक है? ठीक है? So let's talk about first paranoid PD. So people who have paranoid PD, they are very suspicious. They're always suspicious of others. They think that others might be trying to take advantage of me. They are suspicious of the intentions of others. And they're very sensitive. They think others want to harm me. They think others want to harm me. They keep grudges. They don't forget. And they don't forgive. For example, say you took their pen 1 year back. Now they have not forgotten it. There is a diary in which they have written your name, the name of that pen, and the date and time. And the day they get a chance, they will take away your pen. So they don't forget, they don't forgive. They're always suspicious that others want to harm me. And they believe in conspiracy theories. They think that something is going on behind the scenes. Some kind of conspiracy is being made. People are getting together against me. So this is paranoid PD. People who are suspicious. Then we have schizoid PD. They are the loners. They prefer staying alone. They don't like other people's. So they prefer solitary activities. They'll prefer doing things which they can do by themselves. They're more happy thinking, lost in their daydreaming, lost in daydreaming and fantasies. They're emotionally cold. They don't show too many emotions. They don't get attached to people. Whether you like them or whether you dislike them, they don't care. They don't care. They don't show too many emotion. They don't show too much love. They don't show too much anger. Whether you like them or not, they don't care. They also have little interest in sexual activities. Why? Because they don't like other people. To have a sexual activity, you need at least another person. And they don't like other people. So they don't like sexual activities either. They are happy with themselves. This is schizoid PD. The people who love to be with themselves only, they don't like other people. Then you have schizotypal PD, which has many characteristics same as schizoid PD, but they tend to have odd and eccentric thinking and behavior. Their thinking pattern is weird and their behavior pattern is weird. They think in weird ways. They behave in weird ways. Sometimes the way they communicate is difficult to understand. It is difficult to understand. They have magical thinking. Things like, what is sixth sense? What if dinosaurs come back? What if Chat GPT takes over and becomes our king? All these things they are very interested in. Magical thinking. They may have illusions and momentary hallucinations during time of stress. When under stress, they may even have illusions or hallucinations. And like schizoid PD, they also don't have any close relationship. So schizotypal PD are very similar to schizophrenia. They are said to be one step away from schizophrenia. They don't have frank delusions or hallucinations, but their behavior is odd, their thinking is odd, they may have illusions and hallucinations also. So they are kind of one step away from schizophrenia. Schizotypal PD. Schizotypal PD. Khushi is asking, how is delusion of persecution different from paranoid PD? So that's the point. Here we don't have delusion. Or in paranoid PD, we don't have delusion. The person is suspicious. The person is suspicious, but there is no delusion. Delusion is beyond suspiciousness, no? In delusion, you have to have a fixed belief. Even with evidence, the belief should not break. And suspiciousness is he doing something against me? Delusion is he wants to kill me, right? So it's a difference of level. In delusion, you are 100% sure. The management of most of these PDs is psychotherapy and symptomatic pharmacotherapy. Depending on the symptoms, you can give pharmacotherapy or psychotherapy. Psychotherapy and symptomatic pharmacotherapy. Momentary hallucination means hallucination for a moment. For a second, he has hallucination, which stops then. Now we are going to talk about cluster B PD, histrionic PD. So these are the ones who are attention seekers. Attention seekers. They are very dramatic and they have exaggerated emotions. They have too many emotions. Their emotions appear to be fake. So say they come to the office every day and every day they will meet a person whom they see every day as if they are meeting that person after years. And when they are going back home after the day's work, they will say goodbye as if they are going to another country. Too many emotions, unnecessary emotions. And they need to be the center of attention. They will dress in such a way. They will speak in such a way. They will behave in such a way that everybody looks at me. Everybody gives me attention. Everybody give me attention. They may behave in inappropriate ways, sexually inappropriate ways, or they may use physical appearance again to get attention. So all they crave for is attention. They want to be the center of attention. This is histrionic PD. Histrionic PD. Then you have narcissistic PD. They love themselves. They love themselves. They give themselves a lot of importance and they believe that they are special and talented. If you talk to them for 10 minutes, out of 10 minutes, for 9 minutes, they will talk about themselves. They just love themselves. They feel they are perfect. Even if they have not achieved anything, they are sure that they are much better than everybody around. They believe or they fantasize becoming very powerful and very successful. In their minds, they are becoming very powerful and very successful. And that is why they can't tolerate criticism. because they think that they are perfect. If you criticize them, they become very angry that I am perfect. How can anybody criticize me? So they can't take criticism well. And underneath, they have a very fragile self-esteem. Underneath, they have a very fragile self-esteem. Okay? Now we talk about anti-social PD or dissocial PD. नाम में ही है anti-social. They are the people who break rules and regulations. They break the law. They don't care about other person. They don't care about the rights of other person. Even when they do something wrong, even if you punish them, they don't feel guilty. Even after hurting others, they don't feel guilty. In the initial interaction, they may appear very charming, but later on, they show their true colors. And they are likely to use substances. They are likely to use substances. This is anti-social PD. Breaks law, does not care about others, does not feel guilty, substance use. Then we have borderline PD. Borderline PD is a topic which is quite likely to come in the exam, also called as emotionally unstable PD. So these people are emotionally unstable, which means they are very moody. Suddenly their mood changes. Suddenly they start feeling angry. Suddenly they start feeling frustrated. Suddenly they start feeling sad. And they are very impulsive. They take big decisions without thinking it through. Suddenly they will change their course. Suddenly they will change the job. Suddenly they will change the city. Their relationships are also very intense but unstable. When they get into a relationship, it is very intense. It appears as if after the Romeo and Juliet, they are the ones. But their relationship do not last. When they start, it's a very intense relationship, but does not last. And they may indulge in self-injurious behavior like cutting the wrist. Or overdosing the medications. For example, they say that I was feeling so sad, I was feeling so frustrated that physical pain was a relief from the emotional pain. This is self-injurious behavior. They're also not sure about their identity and self-image, which means they do not know what kind of a person they are. What do they want from life? What is their sexual orientation? What is their career preference? They are not sure about their life. They don't know who they are. And they tend to use the defense mechanism of splitting. Splitting means seeing things in black and white. Either they love a person or they hate a person. According to them, either a person is all good or a person is all bad. They don't see things in between. This is called as splitting. The treatment for them is DBT or dialectical behavioral therapy. This question comes in the exams. Dialectical behavioral therapy, it comes in the exams. Now we talk about the cluster C personality disorders. So these four were part of cluster B. Now we're talking about cluster C. The first one is avoidant or anxious PD. नाम में ही है. They avoid others. Why? Because they are very sensitive to rejection. They think that others would not like me. They believe that others would not like me. They believe that others would criticize them or they would not accept them. So they are very afraid of meeting people because they think that others may not like me, others would not enjoy my company, others would criticize me. And that is why they avoid social activities. Now, even the schizoid PD, the patient who had schizoid PD, even he was avoiding social activities, but he liked it that way. He did not want to meet other people. These the avoidant anxious PDs, they want to meet people, they want to socialize, but they do not do it because they are scared that others would not like me. That others would not like me. Now look at dependent PD. Naam mein it's there in the name. They are dependent on others. Somebody else takes decisions for all of their life. All the decisions are taken by somebody else. Which college to go to, in which subject to postgraduate in, whom to marry, how many children to have, in which city to settle, which cloth to wear, which brand to be used. Everything is told to them by somebody else. They are dependent on someone else and they think that I cannot take care of my life. Somebody tell me what to do. So they need reassurance for even basic decisions and they are uncomfortable when alone. ठीक है? And lastly, we have OCPD, obsessive compulsive personality disorder, also called as anancastic personality disorder. These are the people who are preoccupied with rules and regulations. They are preoccupied with rules and regulations. They are always talking about rules, that this thing is against rule. This cannot be done. You are 1 day late. You are 2 days late. You smiled too much. This much laughing is not allowed. They are excessively organized. They are excessively organized. They have made charts for everything about their life. And then they have made a chart about all the charts that they have made. So they are too organized. They have a bad kind of perfectionism, which slows them down. They are never happy with their work. When they do something, they feel that something is missing. I could have done it better. And similarly, if you go to them with some work, they will find 10 mistakes. So their work never gets completed. They don't listen to others. They say, whatever I am saying is the right thing. Follow me. Don't apply your brain. You don't know anything anyways. Whatever I am saying is correct. They are stubborn. You tell them that, sir, now new ways of teaching are coming. They say, no, the best way of teaching is with the help of slides, and they write on those slides. So they are stubborn, inflexible. They don't have any time for leisure. If you make a joke in front of them, they'll say, you are wasting my time. So these people who are only talking about rules, boring, do not want fun, do not listen to anyone, never happy, they are OCPD. They often become the principals of the medical colleges. So treatment for all of them is again psychotherapy and supportive pharmacotherapy. Psychotherapy and supportive pharmacotherapy. ठीक है? All right. Now I'll talk about eating disorders. ब्रेक अभी से कहां से ब्रेक? अभी रुक जाओ थोड़ा सा, एक चैप्टर और फिर ब्रेक लेंगे. Short break after a chapter. Let's talk about anorexia nervosa first. So say I draw 3 images, A, B, C. Which one is normal in weight out of these 3? Which one is normal? A is normal, okay. Which one is fat? Which one is fat? B is fat, है ना? And which one is thin? C is thin. So, why did you say so? Because of something called as body image. So, all of us in our mind have an image of what normal looks like. So, for you, this is what normal looks like. So, in comparison, you call this one fat and you call this one thin. Now, for somebody say what normal looks like, that image is disturbed. There's a body image disturbance. And for someone, say, this is what normal should look like. This is what normal should look like. Somebody has a body image disturbance and this person believes that this is what normal should look like. So for this person, what will A become? For this person, what will A become? For this person, what will A become? Fat. This is what happens in anorexia nervosa. This is what happens in anorexia nervosa. A thin girl looks at herself in the mirror and what she sees is a fat girl. A thin girl looks at herself in the mirror and what she sees is a fat girl. And so she tries to become thin according to her standards, which in reality is very less in weight. So a girl looks at herself in the mirror, a normal girl or a thin girl looks at herself in the mirror, and what she sees is a fat girl. So she keeps on losing more and more weight and ends up becoming even more thin. This is anorexia nervosa. See, a thin girl is looking at herself, but what she sees is a fat girl. What she sees is a fat girl. So this is called as disturbance of body image. Body image is the way in which one's body is perceived. So this is disturbed. And because she is trying to become thin, she restricts the energy intake, leading to a blood body mass index of less than 18.5 kilogram per meter square. So ICD-11 defines it as less than 18.5 kilogram per meter square. Lesser is the BMI, the more severe is anorexia nervosa. Lesser the BMI, the more severe is anorexia nervosa. Lesser the BMI, the more severe is anorexia nervosa. Now, despite being very thin, these patients have a very high fear of gaining weight. And because they keep on losing weight because of starvation, they start developing certain signs and symptoms like amenorrhea. In post-pubertal females, amenorrhea is very common. They also develop lanugo, which are neonatal hairs. Why does it develop? Because of very low weight, the endocrine abnormalities start to develop. So their FSH falls, their LH falls, the gonadotropin releasing hormone falls. All of this leads to amenorrhea. Whereas the cortisol increases. Of course, cortisol is the stress hormone, so it increases. Now, because you are losing a lot of body fat also, you are losing protein also. So you have hypothermia and dependent edema. The overall metabolism is slowed down because the calories are not there. So even bradycardia develops. Harshit is asking why lanugo. Harshit, as I said, it's all because of endocrine abnormalities. The weight becomes so less that all hormones start getting disturbed. Because of it, these things start to develop. Anorexia nervosa is usually seen in adolescent females. So as I said, because of the changes in the hormones, if the patient is adolescent, the sexual development becomes delayed. And if the person is already an adult, the interest in sexual activity decreases. So this is what I just wrote down in the last slide. Now, one of the problems with anorexia nervosa is these patients are very secretive and they deny having any symptom. They'll say, no, my weight is perfectly fine. I'm not thin and I take enough food. So they deny having any symptoms. That is why it becomes so difficult to treat them. So almost always seen in females, but it can be seen in males also. The sex ratio is something like 7:1 or 8:1, much more common in females. Now, what is the meaning of the term anorexia? Anorexia means loss of appetite. So the name anorexia nervosa is the misnomer. Because what is the meaning of misnomer? Wrong name. Anorexia nervosa is a wrong name. Why? There is no anorexia in anorexia nervosa, which means the appetite of the patient is fine. The patient feels hungry, but she does not eat because she is scared of getting fat. So there is no anorexia in anorexia nervosa. There are two subtypes of anorexia nervosa: restricting type and binge eating purging type. In restricting type, food intake is restricted. In binge eating purging type, along with restricted food intake, there are episodes of binge eating and purging. Binge eating and purging. What is binge eating? Eating a lot of food. Purging, vomiting it out. Vomiting it out. Binge eating, eating a lot of food. Purging means vomiting it out. So this is binge eating purging type. The treatment. Now, if the weight becomes too less, or say the patient develops dehydration or developing electrolyte imbalances, or the weight becomes less than, the weight loss is more than 20 of the weight required. Say the patient was supposed to be 50 kg on the basis of height and she has lost more than 10 kgs. 20% of 50 is 10. In that case, you admit the patient. This is called as significant weight loss. This is called as significant weight loss. After admitting, you do the behavioral therapy. Basically, when the patient eats properly, that behavior is encouraged. If she does not eat, that behavior is discouraged. You give some medications like SSRIs, TCAs, or cyproheptadine. So after admission, what is done? The calorie intake is slowly increased. You slowly increase the calorie intake. Say the patient was taking 800 calories a day, you gradually increase it to 1000, then 1100, then 1200. Sometimes what happens is, even after increasing calorie, there is no weight gain. Then what do? So then you observe the patient for 2 hours. After meals, and you lock the washroom. Sometimes what patients do is, in front of the staff, they will eat and then they will quickly go to the washroom and they will vomit it out. That is why they don't gain weight despite increasing calories. So you observe the patient for 2 hours and you lock the washroom. So this is what can be done. Now let's talk about bulimia nervosa. Now bulimia nervosa is also seen in females and it is primarily characterized by episodes of binge eating. In binge eating, large amount of food is ingested in a short duration of time. In a span of 5 minutes, you eat 5 chapatis, then you eat 5 breads, then you eat 5 pastries, then you eat 5 cookies, then you eat 5 bananas, and finally when nothing is left, the banana skin, the kele ka chilka, you eat even that. Whatever is coming in front of you, you are just eating it. You can't stop yourself. Now you have eaten all these things. Now you are feeling that what? Now I will gain weight. You are now afraid of gaining weight. So you do something to stop weight gain. What is commonly done? You put 2 fingers inside the oral cavity and you try to vomit it out. So this is purging by using self-induced vomiting. By using self-induced vomiting, you can also use laxatives or diuretics or emetics or anorectics. So these can also be used to bring down the weight. So there can be self-induced vomiting or inappropriate use of these things. Another way is hypergymnasia, extreme exercising. So after eating all these 5 chapati, 5 cookie, you go for a 5-kilometer run to burn the calories. That is called as hypergymnasia. Now they also have fear of gaining weight. Now the purging is usually done by self-induced vomiting. If you are putting fingers repeatedly in your oral cavity, the knuckles, they will get injured against the teeth. So there is formation of calluses on the knuckles. The knuckles, the calluses gets formed on the knuckles. Now because you are vomiting again and again, the HCl, hydrochloric acid, is coming into the oral cavity again and again. It is going to damage the teeth enamel, causing dental caries. Dental caries. Because you are vomiting again and again, your glands, salivary glands get inflamed, leading to parotitis. And if you are vomiting again and again, you are losing acid, you are losing potassium, you are losing chloride. So it can lead to hypokalemic and hypochloremic alkalosis. If you lose acid, it will lead to alkalosis. So hypokalemic and hypochloremic alkalosis. And say you vomit violently, that can lead to tear in the esophagus or the stomach. So Mallory, we see tear, esophageal or gastric tear due to forceful vomiting. Cyproheptadine will increase appetite, although it's not an appetite problem, but still, if you increase appetite significantly, some intake will increase. So please remember that these signs and symptoms are signs of purging, and purging can happen in anorexia nervosa also and bulimia nervosa also. So how will you differentiate? You differentiate on the basis of weight. Remember, in anorexia nervosa, even to make the diagnosis of anorexia nervosa, the BMI should be less than 18.5 kilogram per meter square. Whereas in bulimia, weight is usually normal. Weight is usually normal. Even sexual functioning is usually normal. These patients are not secretive. They take help. And how do you help? The same, CBT and SSRI. Now, this is how you differentiate. Okay. What if somebody has binge eating episodes but no purging episode? The person eats a lot but neither vomits nor exercises. He will become fat. This is what happens in binge eating disorder, which is the most common type of eating disorder. It is the most common type of eating disorder. Only binge episodes, no compensatory behavior. There is no compensatory behavior which causes overweight. The patient becomes overweight. Treatment is similar to bulimia nervosa. नाम है ना binge eating disorder. All the eating disorders are more common in females. All the eating disorders are more common in females. Now INICET asks this question, what is the screening tool? Screening tool for eating disorders. Remember this name, SCOFF criteria. SCOFF criteria. नाम याद रख लो SCOFF. ये तो भूल जाओगे, but remember the name SCOFF. So these are the questions. Do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over eating? Have you recently lost more than 1 stone in 3-month period? Do you believe yourself to be fat when others say you are too thin? Would you say that food dominates your life? Okay. Now we'll talk about sleeping disorders. Do you want a short break? Okay. Let's have a 10 minutes break. We'll start at 7:20. कितनी स्लाइड्स हो गई? Which slide are we on? 271. 60 left ना? We have 330 कुछ ना? हो जाएगा आराम से. All right. Now we'll talk about the sleep disorders. Now in sleep disorders, we can have dysomnia, where there is abnormality in the duration of sleep or quality of sleep, or parasomnias, in which we have dysfunctional events happening. We'll understand when we talk about it. Let's first talk about hypersomnia. Hypersomnia, there would be excessive sleep. The typical disorder is narcolepsy. Now, we'll talk about the symptoms of narcolepsy. We will understand it. In narcolepsy, what happens is the REM sleep intrudes into wakefulness. Usually what happens? When we go to bed, we go into NREM 1, then we go into NREM 2, then we go to NREM 3, NREM 4, and finally we reach REM. In narcolepsy, what happens? You are awake and suddenly REM sleep will intrude. Now in REM sleep, what happens? Do we see dreams in REM or NREM? Do we see dreams in REM or NREM? We see dreams in REM sleep. Mostly we see dreams in REM sleep. We see dreams in both, but the dreams that we remember are we see them in REM sleep. Another thing that happens in REM sleep is there is loss of muscle tone. REM is rapid eye movement sleep. The muscle tone in the rest of the body is lost and only the eyes move. So there is loss of muscle tone in REM sleep. And we said we dream in REM sleep. Is it easy to wake up a person from REM sleep? No, it is deep sleep. Difficult to wake up. Now imagine a person is awake and suddenly REM sleep intrudes. What will happen? I am awake and suddenly REM sleep, I am dreaming. So if I'm awake and I suddenly start dreaming, I will feel as if I'm having hallucinations. And the hallucinations that occur at the time of going to sleep are called as hypnagogic hallucinations. So the first symptom is hypnagogic hallucination. Secondly, in REM sleep, muscle tone is lost. Now if I am awake and suddenly REM sleep comes, I would lose muscle tone, leading to cataplexy, sudden loss of muscle tone. Interestingly, it is usually triggered by positive emotions like laughing. So say you are laughing and suddenly your jaw drops, loss of muscle tone, cataplexy. Third, when REM sleep comes, it is a very deep sleep. So you'll have a sleep attack. Whatever you are doing, you will fall asleep. If I'm teaching, I will fall asleep. If I'm driving, I will fall asleep. If somebody is swimming, he will fall asleep. So there's a sleep attack. Irresistible urge to sleep. And finally, sleep paralysis. Even when they wake up, they're not able to move themselves. This is called as sleep paralysis. So we have got 4 symptoms: cataplexy, loss of muscle tone, hypnagogic and hypnopompic hallucinations, sleep paralysis, and sleep attack. And we can understand all these 4 symptoms by remembering that REM sleep is intruding into wakefulness. Now, what causes it? We have a neurotransmitter called hypocretin or orexin, which keeps us awake. An autoimmune process starts destroying the neurons that secrete this hypocretin or orexin, because of which narcolepsy develop. It's an autoimmune disorder, so it is associated with certain HLA classes: HLA DQB1, 0602 and HLA DR2. HLA DR2 and DQB1 0602. Management, usually we give modafinil to keep the person awake, and we also tell the person to take naps. You ask them to take nap every 3 hours so that there are no sleep attacks. Okay? Yeah, some new drugs have come like pitolisant, usually not asked. Then there is Kleine-Levin syndrome, which is characterized by a triad of hypersomnia, hyperphagia, and hypersexuality. The person sleeps a lot, wakes up and eats a lot, has a lot of sex, and then goes back to sleep. This is clean Levine syndrome, sometimes also called as perfect life. The treatment is modafinil. The treatment is modafinil, which will take care of your hypersomnia. Clean Levine syndrome. Now let's talk about insomnia. Now in insomnia, we have two disorders. There is periodic limb movement disorder and there is restless leg syndrome. Now in restless leg syndrome, what happens? The moment you go to bed and you lie down, you feel as if there is some kind of restlessness in your legs. Sometimes you feel as if some insect is crawling. You are lying down, you feel as if there's something is crawling and you have to move your leg. You move your leg. So the problem is at the sleep onset. You are lying on the bed, but you have to move your leg or you have to walk around to feel better. So the onset of sleep gets disturbed. So this is what is happening. Difficulty in initiation of sleep. And the drug of choice for restless leg syndrome is now gabapentin or pregabalin. Earlier it was ropinirole, but now the drug of choice is gabapentin or pregabalin. Okay? This is restless leg syndrome. Difficulty in the initiation of sleep. In periodic limb movement disorder, what happens? The person is asleep, and suddenly a major muscle group will contract. It's like the leg muscles will contract. What will it lead to? Patient will suddenly move. Now he himself is usually sleeping, but the partner who is sleeping with him, that person gets awake. The patient may or may not wake up, but the partner gets up. So this is leading to non-refreshing sleep. The next day when the person gets up, he is feeling all sleepy because he could not sleep at night. So sudden contraction of muscle group while sleeping can lead to some awakening, but the bed partner is aware. So when he gets up in the morning, does not feel refreshed, non-restorative sleep. And the treatment here is benzodiazepine. So remember, in restless leg syndrome, there was difficulty in onset of sleep. In periodic limb movement disorder, the patient woke up in the night, in the middle of the night, may get up or not, but the sleep get interrupted and the next morning is not feeling fresh. ठीक है? समझ गए? In the periodic limb movement disorder, while sleeping, there is sudden contraction of muscle group, which may break the sleep. Since the patient moves, the bed partner becomes aware. Because the sleep was getting interrupted multiple times at night, in the morning, the person does not feel refreshed. This is periodic limb movement disorder. Use benzodiazepines so that the patient can sleep properly. Benzodiazepines also act as muscle relaxant. Whereas in restless leg syndrome, when the patient goes to bed, feels something is crawling, has to move around to relieve that sensation, because of which sleep onset is disturbed. Now let's talk about parasomnias, which are characterized by dysfunctional events. Most of them occur in NREM 3 and 4. Let's talk about night terror or sleep terror or pavor nocturnus. So usually seen in children. So we said that whatever happens in REM, you remember it the next day. Whatever happens in NREM, you do not remember it. So this is happening in NREM, night terror. What happens? The child sees a scary dream. Gets up in the night, cannot recall what he saw, and does not remember anything the next day. So the child is sleeping, suddenly wakes up and he saw a bad dream, wakes up frightened, cannot tell family members what happened, goes back to sleep, gets up the next day, does not remember anything. Why? Because it happened in NREM 3 and 4. If the same thing happens in REM, the child sees a scary dream, gets up, tells the parents that I saw a scary dream, goes back to bed, the next day remembers that I saw a scary dream and woke up. This would be called as nightmare. So nightmare is, this is a REM disorder. Child sees a scary dream, wakes up, tells the parents, goes to bed, and remembers everything. This is nightmare. This is nightmare. कैसे याद रखेंगे? हम लोग बोलते हैं ना, we say this is my biggest nightmare. The exam was my biggest nightmare. Do we ever say the exam was my biggest night terror? No. We always say the exam was my biggest nightmare because we remember nightmares. We never remember night terror. So nightmare is what we remember. ठीक है? So this is night terror and nightmare. What is somnambulism? Sleepwalking. The child gets up, moves around a bit, and goes back to bed, does not remember anything. In rare cases, there have been case reports that the person is doing activities like dressing or moving around or even driving, right? Remember that the person is not awake. The person is not fully awake. The person is not fully awake. The person is not fully awake. No, he is not conscious. The person is not fully awake. Then we have sleep related enuresis, also called as bedwetting. The child starts urinating at night. It is usually psychogenic, psychological, but before calling it psychogenic, you have to rule out. You have to rule out diabetes mellitus, diabetes insipidus, any urinary tract infection or obstructions. You have to rule these things out. So it may happen because of sibling rivalry. Like say a child is 6 years old, the only child, and now the younger brother is born, and family members are all giving importance to younger brother, and this older one starts to bedwet. This is called a sibling rivalry. So what is the treatment of choice? Bed alarms, which work on classical conditioning. Bed alarms. So basically, the moment child urinates, an alarm starts to ring. The moment child urinates, an alarm starts to ring. So basically, every time child urinates, he immediately wakes up. So gradually what will happen? The urge to urinate would be enough to wake up the child. You are trying to create a link between urination and getting up. And gradually just the urge to urinate should be enough to wake up the child. This is bed alarm. But if somebody asks you what is the drug of choice, it is desmopressin. The drug of choice, overall treatment of choice is bed alarm. Drug of choice is desmopressin. You can also use TCA like imipramine, but they cause a lot of side effects, so not preferred. Now we'll talk about sexual disorders. So first of all, let's talk about gender dysphoria or gender incongruence. Gender dysphoria or gender incongruence. So when a child is born, he is assigned a gender on the basis of usually anatomical sexual organs. Say a child is born and the child has penis and testes. So the assigned gender is male. You say it's a boy. So gender assigned at birth on the basis of sex organs is assigned gender. Now this person who was assigned a gender of boy grows up and say he considers himself as a female. What you consider yourself to be is the experienced gender. There's an assigned gender on the basis of sex organ, and what you consider yourself to be, that is your experience gender. In most of the cases, assigned gender and the experience gender are the same. Say there's a person who was assigned a gender of being a boy, but experiences himself to be a girl. But he does not have any distress. He is not distressed by it. In that case, what is the diagnosis? There is no diagnosis. You can call this person transgender, but there is no diagnosis given. Why? Because patient does not have any distress. But say the assigned gender is that of a male and experienced gender is that of a female, and the person is distressed by it, then you make a diagnosis of gender dysphoria or gender incongruence, which means assigned gender and experienced gender do not match and cause distress to the person. समझ गए? They are not matching and they are causing distress. Only then we make a diagnosis. Otherwise, we do not make any diagnosis. Now, gender dysphoria of childhood. What will happen? Say the child was given an assigned gender of being male, but his play activities are similar to the other gender. Like he was assigned a gender of male, but he's playing with doll, he's playing kitchen, all the things that usually girls do. So dresses, wearing frocks, dresses and activities are similar to that of opposite gender. But the child is too young. At this time, he does not make much comment about the sexual organs. He may say that he wished that he was a girl, but he would not say anything about the anatomical organs. This is gender dysphoria of childhood. Now this person grows up. Gender dysphoria in adolescents and adults. Now this person clearly says that although he was born as a man, he wants to live like a girl and he wants everybody to treat him like a girl. And now he also says that he is uncomfortable with his penis and testes. Instead, he wants vagina and breast. And this is the line that will come in your exam. The patient says that he is a man trapped in a woman's body or a woman trapped in a man's body. The moment you see this line in the exam, and they give this line every time, mark the diagnosis as gender dysphoria or gender incongruence. Gender dysphoria or gender incongruence. The treatment can go from complete sex reassignment surgery to just hormonal treatment. You can just give hormones or you can do the proper surgery and create sexual organs. As far as your exams are concerned, this is the line. A man trapped in a woman's body or a woman trapped in a man's body. Okay? Now let's talk about sexual response cycle. What are the stages of sexual response cycle? The first stage is desire, when the person wants to indulge in sexual activity. Then comes the stage of excitement, in which the men get erection and the females get vaginal lubrication. Excitement or arousal phase. At the end is called as plateau phase, when the excitement reaches its peak. Then you have orgasm phase, NEET PG question, which is the shortest phase in sexual response cycle, orgasm. And finally, there is resolution, when the person goes back to resting stage. So there is desire to indulge in sexual activity, followed by a state of excitement, followed by orgasm, and followed by resolution. Now we have different disorders in different stages. One disorder that we need to remember is the disorder of excitement phase, erectile dysfunction or male erectile disorder. Erectile dysfunction or male erectile disorder. Obviously, what is happening in erectile disorder? Inability to achieve or maintain erection. Inability to achieve or maintain erection? The most common cause of erectile dysfunction is anxiety, psychogenic. Psychogenic. Most common cause of erectile dysfunction is psychogenic. If you want to know whether you are post-pubertal or pre-pubertal, you can just look at yourself now. If you're making smileys and laughing at this topic, it means that you are a kid. You should have been in 9th class or 10th class when kids laugh. You should not have been a doctor. So it's a good way for you to understand whether you are pre-pubertal or post-pubertal. Chalo. हाँ. So most common cause of erectile disorder is psychogenic. When a person is anxious, he would not be able to get an erection, leading to erectile disorder. But diabetes can also cause erectile disorder. Why? Because diabetes can cause vasculopathy and neuropathy. The vessels may get damaged or the nerve may get damaged. Okay? So it can also be organic, but mostly it is psychogenic. How will you know just on the basis of history whether it is psychogenic or not? Men tend to have spontaneous erections during REM sleep. And REM sleep usually happens in the morning hours. So if you simply take history from a male, that are you able to get erections in the morning? And if he says yes, but he's not able to get erection during intercourse, what does it tell you? Because he's getting erection in the morning time, it means that his body is working fine. There is no vessel problem, there is no nerve problem, there is no hormone problem. So history of morning erection goes in favor of psychogenic ED. If a person is not able to get erection even in the morning, it is likely that he has organic ED. So history of morning or nocturnal erections goes in favor of psychogenic ED. Lack of early morning erections is probably towards organic ED. And you can also do two tests: penile plethysmography and nocturnal penile intumescence. You check the same thing. If the person is getting morning erections, your diagnosis is more towards psychogenic ED. Not getting morning erections goes towards organic ED. Okay? Alright. How do you treat erectile disorder? Simplest treatment is phosphodiesterase 5 inhibitors like sildenafil and tadalafil. They will increase the blood flow. You can also give alpha antagonist like phentolamine, but there are more side effects. And even prostaglandins can be given injectable or transurethral like L-prostadil. But again, it is inconvenient to use. So best treatment remains your PDE5 inhibitors like sildenafil and tadalafil. These are two tests that you can do to see whether the person is getting nocturnal erections or not. So if he is getting erections, psychogenic ED. They are the name of the test. Okay? Along with these medications, you can also do a therapy called as dual sex therapy or sex therapy, also called as Masters and Johnson's technique. The Master and Johnson were a doctor and a nurse who were working on sexual disorders. So they gave this technique, Master and Johnson technique, and later on they got married also to each other. So this is called as Masters and Johnson's technique. And in this technique, the couple is treated. Erectile disorder is of course a problem of men, but in the therapy you treat it as a couple. You tell them that you guys are focusing too much on intercourse, which is causing a lot of anxiety, because of which erection is not happening. Rather than focusing on intercourse, improve the communication and things will settle down. And you tell them certain exercises called as sensate focus exercises. Step by step you teach them exercises to improve the communication and take the person towards intercourse. So this is sensate focus exercise. ठीक है, याद रखना, नाम याद रखना, ये क्वेश्चन एग्जाम में आता है. Alright. Now let us talk about the disorders of orgasm phase. premature ejaculation. If the ejaculation happens repeatedly in less than 1 minute, it is called as premature ejaculation. Most commonly, it is psychogenic. Remember, we said that one of the side effects of SSRIs was delayed orgasm. Here it becomes therapeutic. Here it becomes therapeutic. Okay. There are two techniques that can be used in PME and they have been asked in your NEET PG exam. You have got squeeze technique and you have got stop-start technique. In squeeze technique, you teach the patient or the partner that when ejaculation is about to happen, the penis should be squeezed at the coronal ridge of glans penis, just below the glans penis. And in stop-start technique, as the name suggests, when the person feels that he's about to ejaculate, stop having intercourse, take a gap of 30 seconds, again start having intercourse. So ये squeeze technique याद कर लेना, एग्जाम में आती है नीट पीजी में, ठीक है. And the sex therapy that we talked about in erectile disorder can be used here also. For all the disorders, you can use it. So this is your PME. The most common sexual disorder in females is called as anorgasmia. Inability to achieve orgasm, mostly psychogenic. And then some patients are present with delayed ejaculation, where the ejaculation is delayed. Okay? We have got two terms, dyspareunia and vaginismus. So dyspareunia is pain during intercourse or before or after, and vaginismus is involuntary contraction of vagina. When intercourse is attempted. Okay? They happen together. They usually happen together. चलो ठीक है. Paraphilias we can avoid discussing because कर लेते हैं, वैसे फोरेंसिक में सर पढ़ाते ही हैं, बट पढ़ लेते हैं. It will take 5 minutes. So sexual arousal and orgasm is achieved by stimuli that are deviations from the normal behavior. Deviations from the normal behavior. So in voyeurism, the sexual arousal is achieved by watching others. Watching others. क्या बोलते हैं इसको? और peeping tom, right? Peeping tom. So by watching others, peeping tom. Exhibitionism by exposing themselves. Embarrassing यार, जो तुम लोग हंस रहे हो ना, हंसी आ रही तुम लोगों को, बताओ. It's such a matter of shame that we are teaching doctors and this is the situation. When it's simply sad. But these guys will become doctors and they'll enter the clinics, and imagine somebody coming with a sexual problem, which is a huge thing for that patient. Imagine how will they behave. And these are like 25-year-olds, not 15-year-old or 16-year-old. Shameful. You should be ashamed of yourself. Frotteurism. Frotteurism is rubbing genitals against unsuspecting individuals. Sadism, sexual arousal by giving pain. Masochism, stop reaction. Why should I stop reaction? हंसने तो जिसको हंसना है, जिसको जो हंस रहा है उसको थोड़ा शर्म तो आने दो. Masochism by getting pain. Giving pain by getting pain, given pain. Pedophilia, of course, involvement with children. Fetishism is use of non-living objects or non-genital parts. Like one of the commonest is foot fetish, right? People getting sexually aroused by feet. Foot fetish. Transvestism has been asked in INICT, also called as Eonism, by cross-dressing. By cross-dressing. By cross-dressing. Scatologia, by saying obscene words. So what they do, they call people and they say some obscene words. Necrophilia, with dead body. Zoophilia, animals. Coprophilia, feces, sexual arousal with feces. Urophilia, with urine. Klismaphilia, with enemas. And lastly, partialism, where the person focuses on only one body part, and that is what gives sexual arousal. Scatologia is obscene words. Obscene words. ठीक है? चले आगे. Treatment is all therapy, not easy to treat. Therapy. Yuvraj is asking what is obscene. Obscene is something objectionable, something wrong. गंदी भाषा, गलत शब्द. हाँ. Klismaphilia is enemas, sexual arousal by taking enemas. Chalo, let's talk about child psychiatry now. So in child psychiatry, first of all, we'll talk about ADHD, attention deficit hyperactivity disorder. So it is a neurodevelopmental disorder. What does it mean? As the CNS is getting formed, as the CNS is developing, the abnormality in the development of your nervous system is leading to development of ADHD. ADHD. Okay? And as you can expect, ADHD is more common in boys, right? Boys are more likely to do all these hyperactivity things. Now, the symptoms of ADHD are, as it is there in the name, attention, deficit, hyperactivity, and impulsivity. So, inattention, hyperactivity, and impulsivity. What is inattention? So, in the exam, you will get history like the child is not able to follow classwork. Gets distracted easily. Jumps from one task to another. Without completing it. Okay? So this is the history that you will get for inattention. Inattention. Hyperactivity, the history you'll get is keeps on roaming in the class. Does not sit at his chair. Disturbs other students also by making stupid smileys. Disturbs other students also. And then we have impulsivity. Cannot wait for turn. Like say, you ask all the kids to stand in a line and you're giving them something. The person with impulsivity would not be able to wait for his turn. He will jump the queue and will ask for the thing first. Answers before the question is complete. Answers before the question is complete. ठीक है, सो दिस इज इंपल्सिविटी. सो apart from these, there can be some soft neurological signs. What is the meaning of soft neurological signs? Signs that can be elicited with detailed examination only. With detailed examination only. Normally, you would not find these signs, like copying age appropriate figure. There's an age when the child can copy it, circle, square, rectangle. That is impaired, or not able to do the right left discrimination. To make a diagnosis of ADHD, the onset of symptoms should be before 12 years of age. Before 12 years of age. ठीक है, ऐसा नहीं है कि आपको ADHD पहली बार 30 साल की उम्र में हो गया. It is unlikely. The problem with ADHD is the symptoms are such that inattention, impulsivity, that these symptoms can be seen in so many cases. Simple anxiety disorder can present with these things. So to make a diagnosis of ADHD, the onset has to happen before 12 years. And yes, there can be adult ADHD. So if the child is having predominantly symptoms of inattention, we call it ADHD predominantly inattentive. If there is hyperactivity and impulsivity, we call it predominantly hyperactive impulsive. And all of them are there, we call it combined. As simple as that. Combined. ठीक है. Now ये नीट पीजी का क्वेश्चन है. नहीं, ये नीट पीजी का FMG में क्वेश्चन आया था. That children who have ADHD may also develop conduct disorder in adolescence. Right. Now, as the children age, around 50% of them achieve remission by puberty. As you age, symptoms tend to go away. But the problem is, in whom the symptoms do not go away, they may end up developing substance use disorder or antisocial personality disorder or depression. Say your symptoms are not improving, you are not able to study, you can't sit, the teacher throws you out of the school, you start developing depression, or you are thrown out of the school, you get into the company of unsavory people, antisocial people, and you may also develop antisocial personality, may get into things like alcohol, right? Conduct disorder bhi padhayenge. We'll talk about conduct disorder. So ADHD is a serious illness and should be treated with pharmacotherapy. Would be treated with pharmacotherapy. So what is the drug of choice for ADHD? We give stimulants like methylphenidate. Methylphenidate is considered as the drug of choice. You can give other stimulants also like amphetamines and modafinil, but methylphenidate is considered as better. And in some cases where you cannot give stimulants, you can give drugs like atomoxetine, ABC, atomoxetine, bupropion, clonidine, even guanfacine and venlafaxine. Remember this table. It has been asked multiple times. Remember the table. It has been asked multiple times. Ninja is saying finally a mnemonic from sir. Kyun? I told you about DABDA, DABDA. That was my mnemonic. DABDA. और कोई भी नहीं था. ओशियन. ओशियन बताया तो पर्सनैलिटी डिसऑर्डर में ओशियन. Shiva is asking why non-stimulant is used. So stimulants can have a abuse potential. Say somebody has a strong history of abusing drugs, or family history of abuse of drugs. So you try to avoid stimulants in those patients. So you go for drugs like atomoxetine. हाँ, रैश डी, गोवा, साइज कैप्स. थैंक यू गाइस, मैं भूल गया था. निंजा देख लो, इतने सारे निमोनिक है हमारे. फिनिश, कैपग्रास. थैंक यू किड्स, थैंक यू फॉर कमिंग टू माई रेस्क्यू. अभी मैं तुमसे तो नाराज हुआ था हंसने के लिए, मैंने माफ कर दिया. अच्छे बच्चे हो तुम लोग. थोड़े गधे हो, इमेच्योर हो, बट बच्चे तो बच्चे ही हो. ठीक है. All right. So along with the medications, what else can you do? You can also give behavioral therapy and cognitive behavioral therapy. Behavioral therapy or cognitive behavioral therapy. In psychiatry, when you don't know the answer, you can write CBT. CBT can be taken for maximum thing. All right. Now let's talk about a group of disorders called as pervasive developmental disorder. Although this category has been now removed, but they still keep on asking the question, so we are including it. So pervasive developmental disorders are a group of neurodevelopmental disorders. They are a group of neurodevelopmental disorders, and the most important of them is autism. Now, autism is characterized by two main symptoms. First is impairment in social interaction and social communication. Impairment in social interaction or social communication. So what happens? The child is not able to interact socially. So as an infant, he would not be able to make eye contact, does not look into the eyes. There is no social smile. There is no social smile. There is no anticipatory posture. What is anticipatory posture? Say if you want to pick a child, what do? You do like this. And if the child wants to come to you, he will do like this. If he does not want to come to you, he will do like this. So this is called as anticipatory posture. The child is anticipating then that I'm about to be picked and he is helping you. This is a social interaction. The child wants to come to you. So this is missing. The child does not give you a social smile. The child does not even look into your eye. The child does not show any attachment to parents. Normally what happens? If say the child is 2-year-old or 3-year-old, the moment mother comes back from somewhere or the father comes back home, the child will come and run and hug the parent. But here, the child does not show any attachment, does not care. The child is not able to make any friends as he grows up. As he starts growing up, he is not able to make friends. So these are abnormalities of social interaction or communication. Then there are restricted repetitive patterns of behavior. Remember we talked about stereotypical movements. I showed you this. So such kind of spontaneous purposeless movements can be done. The child tends to play in the same way again and again. Normally what happens? The child learns up some play, 15 minutes after it, he gets bored, throws it, starts doing something else. But these kids play in the same way again and again for months or weeks or days. They make the same kind of movements. And this was a criteria earlier. That there is impairment of communication and language. The language milestones are delayed. The child motor milestones are normal, but the language milestones are delayed, and he makes abnormalities in making sentences or in the pronouns. Now this criteria has been removed. So we are left with two criteria now: restricted repetitive patterns of behavior, abnormal social interaction, and social communication. So it has got a strong genetic basis, autism, and the onset is before 3 years of age. Autism onset is before 3 years of age. There are many congenital syndromes with which autism is associated, like Fragile X syndrome, congenital rubella, tuberous sclerosis. So basically, association with these syndromes tell us that it has got a strong genetic basis. And around 30% of these children have comorbid mental retardation, which worsens the prognosis. Pronoun reversal is, rather than saying I want to eat, he says you want to eat. I-you confusion. There is no definitive treatment for autism. You do things like structured classroom teaching, behavioral therapy, and 2 antipsychotics have been approved for autism: risperidone and aripiprazole. Risperidone and aripiprazole. Okay. Now another disorder which is similar is called as Rett syndrome, often asked in the exam, almost exclusively seen in females. Almost exclusively seen in females. It's a very unfortunate disorder. Why? For the first 5 months of life, the child is absolutely normal. And between 5th and 48th month, things start to happen. The first of all is deceleration of head circumference. What does it mean? The remaining body will continue to grow normally, but the growth of head is much slower. So in comparison to body, the head keeps on becoming smaller and smaller, finally leading to microcephaly. One of the common question asked is, all of the following are seen in Rett syndrome except, and one option they give is macrocephaly. So there is no macrocephaly, microcephaly. Then there is loss of acquired hand skills and speech. What does it mean? Say the child had learned pincer grasp. Now she will forget it. She will go back to palmar grasp. Whatever she had learned, she forgets it. And the speech also. Say she was able to say sentences. Now she goes back to bisyllables or monosyllables. So whatever she had learned, speaking and with hands, she forgets it. Regresses. There is development of poor gait, not able to walk properly. And the 3 symptoms of autism: language disturbance, abnormal social interaction, and restricted repetitive behaviors. Restricted repetitive behaviors also show up. 75% of these children have seizures, and this is an INICET question. A new drug has been approved recently for Rett syndrome called as trofinetide. Prognosis is not good. There was another syndrome, again this has been removed now. It was called as Asperger's syndrome. It had all the symptoms like autism, but there was no language dysfunction. There was no language dysfunction. So now in the newer classification, in DSM-5 and ICD-11, what they have done is they have changed the name. They have combined all these disorders like autism and Asperger's syndrome, and they have now created a single diagnosis of autism spectrum disorder, and language dysfunction has been removed as a criteria. Rett syndrome still exists. It has been kept elsewhere, and autism and Asperger's syndrome. There was another one called as Heller's syndrome. All of them have been combined into autism spectrum disorder. Okay? Now let's talk about mental retardation. The newer name of mental retardation is intellectual disability. So what is mental retardation? Incomplete development of intellectual functions and adaptive skills. What is the meaning of adaptive skills? The skills required to live a normal life. Like what? To live a normal life, you have to have some kind of work skill. You should be able to do something. You need to have some basic skill of money, how to count money, how to understand the calculations. You need to have some kind of interaction also. So all these skills are, if they are lacking, and if the intellectual functioning has not developed, then we make a diagnosis of intellectual disability. Intellectual disability. Now this diagnosis is quite dependent on the calculation of IQ. IQ is intelligence quotient. IQ is intelligence quotient. What is IQ? Mental age divided by chronological age multiplied by 100. So basically, what is chronological age? The age of the child. So the child is 10 years old. So chronological age becomes 10. How do we calculate mental age? We give a test to the child. Based on the result of the test, the mental age is decided. So say the age of the child was 10 years and his mental age came out to be 7. So IQ becomes 70. Okay? So normal IQ is between 90 to 109. Below 70, we say mental retardation. And in between, we call it borderline intelligence. So mental retardation is below 70. So 90 to 109 normal, 70 to 89 borderline borderline intelligence, 70 to 59, 70 to 50 mild MR, 35 to 50 moderate MR, 20 to 35 severe MR, and less than 20 is profound. So 70 to 50, 50 to 35, 35 to 20, less than 20. Okay. There are many tests. Different types of tests are done. We have WISE, Wechsler's Adult Intelligence Scale, SFBT, बहुत सारे हैं. The terms like imbecile, idiot, moron, they were used earlier. Nowadays, they would not be asked in the exam. I am hoping they would not be asked in the exam because they are no longer used and they're also considered offensive. I mean, calling a child moron or imbecile, I mean, this is like something that should not be done today. But if the doctor is moron, then he can call others moron. Right? Chalo. The most common congenital cause of mental retardation is Down syndrome. Mental retardation is Down syndrome. The second most common congenital cause of MR is Fragile X syndrome. Both these questions have been asked. Most common chromosomal cause of mental retardation is Down syndrome. Second most common chromosomal cause of MR is called as Fragile X syndrome. Call of Duty, हाँ ये देखो आ गया होगा Call of Duty. So children with mental retardation can develop behavioral problems. How would you treat them? With contingency management. Contingency management. What a behavioral problem? Like the child throws things, bites himself, bites others, punches others. So if these behavioral problems are there, what will you do? You do contingency management. Basically in contingency management, what do? You reward good behavior. Say the child finishes food without spilling, you give him a toffee. But if he spills the food, you do not give him the toffee. So you are trying to increase the frequency of desirable behavior. Increasing the frequency of desirable behavior. This is called as contingency management. Yeah, you can call it reinforcement. Now let's talk about learning disorder. Now in learning disorder, what happens is in one of the academic skills like reading or writing or arithmetic, the child is weak. Otherwise, intelligence is usually normal, but is lacking in one of the scholastic or learning skills. So then we use diagnosis of learning disorder. So impairment in one or more scholastic skills out of proportion to intellectual functioning. Even if the IQ is normal, in one thing he is lacking. So if he is lacking in reading, then we call it dyslexia. If he is lacking in writing, we call it specific spelling disorder. And if he is lacking in arithmetics, we call it specific disorder of arithmetic skills. If is lacking in all, we call it mixed disorder. So the history would be the child reads very slowly or makes a lot of mistakes. देखिए ना मूवी तारे ज़मीं पर. It's a beautiful movie, and I think it's one movie that made a huge contribution in the life of people who had this problem. I'm personally a very big Amir Khan fan because I think his work has made a real difference in the life of people. He made some statements against doctors, but even good people sometimes make mistakes. We should not be so judgmental. But he changed the life of so many kids. Think about it. है ना? तो बड़ी चीज होती है. So if the problem is in reading, dyslexia, problem is in writing, specific spelling disorder, and problem with maths, specific disorder of arithmetic skills, and all of them mixed disorder. Anant Kaushik कह रहे हैं Asperger's once again. Anant, Asperger's syndrome is no longer a diagnostic entity. It was diagnosed as autism minus language dysfunction. Rest everything was like autism, but there was no language dysfunction. All right. Now we talk about disruptive behavior disorder. नाम ही में ये देखो, disruptive behavior disorder. So see, this disruptive behavior disorder can be of two types. it can be of a lower level, milder variant called as oppositional defiant disorder. Now look at the term oppositional defiant disorder. Defiance. Basically, the child does not obey the elders, does not obey elders, even annoys them, irritates them, annoys them. So it's a milder variant where the child is not listening to the teacher, not listening to the parent, even annoying them, but that's it. More severe is conduct disorder. Now the child is doing more serious violations, like he is stealing, like he is bullying others, he is cruel to animals. Truancy. Truancy means running away from the home. Lying a lot. So, in oppositional defiant disorder, only disobeying and annoying. Conduct disorder, more serious things. ठीक है? So अब देखो, conduct disorder में stealing, lying, aggression, bullying, cruelty, disobedience, running away from school. Later on can develop antisocial personality. Remember, in antisocial personality also we said that no regards for rights of others, breaks laws and rules and regulations. And the other one is oppositional defiant disorder, just negative and defiant towards adults. All these things are not there. Management is very difficult. You can try therapy, difficult to do. Low dose antipsychotics can also be used. Tic disorder. So what are tics? They are sudden, brief motor movements or vocal tics. So like some people you'll see some people do like this. This is a motor tic. Or some people do something like this. Sudden movements, right? So these are motor tics. Some people do like these are vocal tics. So tics are brief, rapid motor movements or vocalizations. So they occur in response to internal urges. The person feels like moving the shoulder. He can stop it for some time, but then the urge increases and then he does this movement, right? This is occurring in response to internal urges. They can be simple or complex. Simple when only one muscle group involved. Complex, multiple groups involved. So all these are simple. In complex, there may be more complex movements, right? Echolalia can also be a presentation of tic. कहाँ पढ़ा था हमने echolalia? Repetition of speech. We talked about it when we were discussing schizophrenia. Yeah. So echolalia is repetition of speech. Echopraxia is repetition of behavior. Coprolalia is obscene words, use of obscene words, dirty words, gande shabd. And copropraxia is obscene posture or obscene movements, like showing the middle finger, right? That would be considered as a copropraxia. Coprolalia is using a cuss word, gali de dena. Copropraxia is making obscene gesticulations. So these can be a part of tics. If a patient has multiple motor tics and one or more vocal tics, then it could be called as, or the child may be diagnosed with Tourette syndrome. The onset of Tourette's is between 4 to 6 years. It peaks between 10 to 12 years. And in adolescent or young adulthood, remission in half to 2/3. This is plain fact. That has been asked in the exam. That's why I've included it in the slides. And it's more commonly seen in males. The treatment, where did we talk about habit reversal therapy? Which disorder? We talked about it in trichotillomania. So we said, rather than doing this, you do something like this. Similarly, rather than doing this, you may do this. right? You replace one movement with another movement, one movement with another movement. That is habit reversal therapy. Habit reversal therapy is you replace one movement with another movement. Another acceptable. The first line are alpha 2 agonists like clonidine and guanfacine. Although the FDA approved are your antipsychotics, but the first line treatment is clonidine or guanfacine. And other drugs that can be used are antipsychotic, but you don't want to give antipsychotics to kids. So you prefer giving alpha 2 agonists. Janvi is saying, sir, can tics go permanently by time? Yeah, we talked about it, no? That by adolescence or young adulthood, in almost 2/3, there may be complete remission. All right, psychoanalysis. Which slide are we on? 317. 20 left, na? So how about this? Rather than going for dinner, we just take a short break and then we finish it off. Dinner finish करने के बाद करना, ठीक है? We take a short 10-15 minutes break and then we complete it so that the dinner you can do easily. ठीक है? So we take a just 15 minutes break. 8:45 will start. And for those of you who are saying that just finish it off, भाई थोड़ा रहम कर लो मेरी vocal cords के ऊपर. Have some mercy on my vocal cords. करें खत्म? So now we will talk about the second last chapter, which is psychoanalysis. So who is the father of psychoanalysis? Sigmund Freud. Sigmund Freud is considered as the father of psychoanalysis. ठीक है? So what does this theory say? It says that childhood experiences and unconscious internal conflicts can cause, or rather than that, result in development of psychiatric disorders. So this is an old hypothesis or old theory, which is usually not much accepted nowadays. And sometimes they do ask a question from it, not commonly. So we'll discuss some important points. So it says that childhood experiences and unconscious internal conflicts is responsible for development of psychiatric disorders. So the term psychoanalysis is used for both the theory as well as the treatment method based on it. So in 1900, 125 years back, Freud published a book called as Interpretation of Dreams. In this book, he said that there are three parts of mind. One is called as conscious mind, other is called as preconscious mind, and the third one is called as unconscious mind. So everything that you remember is a part of your conscious mind. Things that you cannot recall are a part of your unconscious mind, and things that you can remember or recall by putting efforts is in your preconscious mind. For example, if I ask you to remember or recall the face of your 5th class teacher, if you can recall her face, it was in your preconscious. But if you cannot recall it, it has gone into your unconscious, you can't access it. So Freud said that there are a lot of distressing memories and certain instincts which are a part of unconscious mind. And he said that if somehow we can bring them to the conscious mind, the psychiatric illness will get treated. The psychiatric illness will get treated. If we can bring the forgotten memory into the conscious mind, the psychiatric illness will get treated. So he gave various methods. He gave various methods for this purpose. Like he used hypnosis in his patients to access the things which are in the unconscious. but he found that it is not so effective. He found it ineffective. Then he gave a technique of free association. In free association, what happens is there is unguided communication, which means you don't guide the communication. Basically, the therapist and the patient sit together. In fact, the patient is made to lie on the couch and the therapist sit at the backside. And then you ask the patient that whatever is coming to your mind, you speak it, you say it. So the patient keeps on saying whatever comes to his mind. The therapist sits at the back, he keeps taking notes. And when the patient speaks like this without any censorship, it is called as free association. So when you do that, sometimes things that are hidden in the unconscious mind, they slip out. There are slips of tongue, and these slips of tongue are called as parapraxis, and they are noted by the therapist and then interpreted by the therapist to understand what is hidden in the unconscious mind. ठीक है, समझ गए? So far so good. The patient keeps on saying and something will come out of the mouth, slip of tongue, and the therapist will note it and interpret it. So when patients do so, sometimes they are able to recall long forgotten memories. Like remember when we were discussing about dissociative amnesia, we took an example that a girl had an accident in which she lost her parents, but she is not able to recall that accident. She is not able to recall that event. You remember it? Imagine 5 years have passed and the girl still does not have any recollection of that event. And now you are sitting with the patient and you are trying to do the free association with that girl, and suddenly that girl is reminded of that accident. And now she says that I remember the train was going, suddenly there was a big break, everything fell down, people started shouting, people started crying. I looked around, parents were on the ground, and then she recalls everything and she starts howling, she starts crying, she's able to recall everything, but there's a lot of emotional discharge. That is called as abreaction. Recall of long forgotten memories with release of emotions. So this is called as abreaction. Okay? Now there are two other things that happen in therapy sessions which follow psychoanalysis: transference and counter-transference. Transference is the feeling that the patient develops for the doctor, and the counter-transference is the feeling that doctor develops for the patient. And these are also interpreted in therapy. What is the meaning of feelings here? Not the feelings that you are thinking of. It's not that. Say you start doing therapy sessions. Say you are a middle-aged man and you start doing therapy of a young girl, and you sense that in the first session itself, the girl is very hostile. You have not said anything wrong, but the girl is very hostile. Why is girl hostile? Because the girl is seeing in you her father with whom she had a very bad relationship. Now, how does it help you? It gives you a hint that there is something to do with this girl and her father relationship that is presenting itself in the therapy, and you have to evaluate that relationship. So this is transference, and the opposite becomes the counter transference. So that is how psychoanalysts used to use these feelings to understand what is going on. एग्जाम के लिए याद रखो, पेशेंट टू थेरेपिस्ट ट्रांसफरेंस, थेरेपिस्ट टू पेशेंट काउंटर ट्रांसफरेंस. ठीक है? At the age of around 80 years, Freud changed his theory. He came up with a new theory called as structural theory of mind. Now he said that there are three parts of mind: id, ego, and superego. Id is the part of your mind which works on pleasure principle. The part of your mind which just wants pleasure, enjoyment, is id. The part of your mind which works on morality principle is superego. And who are you in between? Egos. You know that too much of pleasure is not good and too much of morality is also not good. Like if you're sitting in the class, your id is saying, why am I doing this stupid classes? Let me go out to a bar. Let me get drunk. Let me dance on the dance floor and let me sleep on the road itself. Let me have fun. Your superego on the other end is saying, let me do all the classes. After the class, let me revise everything. I will do the late night PYQ, midday PYQ, mid-evening PYQ, mid-afternoon PYQ, all kind of questions that they gave me. I will do everything. And teachers are like gods. Parents are like gods. I am Gandhiji, right? This is all superego. In between, you are sitting and you are saying that, let me listen to the class for 20 minutes more. If it does not stop, I will leave the class and I will watch a movie. So this is how balancing happens. One part of your mind wants to enjoy, other part of your mind is becoming Gandhiji, and in between you create a balance कि चल 10 मिनट और सुन लेते हैं इसको फिर खेलेंगे. This is ego. This is you. And to create such balances, ego uses certain mechanisms called as defense mechanisms. So when id and superego fight, the anxiety increases. To bring it down, ego uses certain mechanisms called as defense mechanisms, which are unconscious. Means when we use defense mechanisms, we don't use them consciously. We just use them unconsciously. So let's talk about some defense mechanisms. Denial. Refusal to accept the reality. So for example, a mother was told that her son died, that her son fell from the roof and has died. Now the mother's ego knew that if mother accepts this news, she would not be able to tolerate it. So what ego does? It takes out the defense mechanism of denial and it blocks the news. So mother is told that your son has died. She says, not possible. Nothing of this sort has happened, and continues washing clothes. This is denial. Refusal to accept the reality. Okay? Then we have projection. Transfer of feelings about a person onto that person. Say there is a husband and a wife. Now husband wants to cheat on wife. Or let's say husband's id wants to cheat on wife. But husband's superego is saying that's a wrong thing. You can't cheat. That's a wrong thing. So what ego does? It says that actually wife is cheating on me. And since wife is cheating on me, even I can cheat. So what he felt about the wife, he started saying that wife feels this for me. This is projection. What you feel for the other person, you say that the other person is doing that to me. This is projection. Freud believed that it is involved in the development of hallucinations and delusions. Today we know that it is not because of any defense mechanism. It is because of dopamine. Acting out. You act on an unconscious desire without becoming aware of it, like it happens in impulse control disorder. Like you are going in a mall, suddenly you pick something, put in the pocket and come outside. And now you're feeling guilty. So you act on something without even becoming aware of it. This is acting out. Passive aggressive. Expression of feelings in an indirect way. Like you ask your brother, younger brother, to get water. He does not want to give you water. So what he does? He goes to kitchen, gets a glass of water and then accidentally slips it. It falls on the ground. So rather than saying no to you directly, he is expressing the feeling in an indirect way. This is passive aggressive. Rather than saying it outright, you do it in an indirect way. Regression. Return to an earlier stage of development. For example, you are studying for many days. You are very frustrated, very bored. You see some kids in your colony playing cricket. You forget about everything. You start playing cricket with them. You play with them for 3 hours. You are trying to Go back to that part of your life for few hours where you could have fun without the stress of an entrance examination. This is regression. You play cricket with kids for 3 hours. Freud believed that it's a part that neurosis is because of regression. Neurosis is a term used for all the disorders like depression, OCD. Nowadays, we don't use that term. But this theory is 125 years old. At that time, those terms were used. Displacement. You transfer emotions from one individual to another. For example, you go back home and your father scolds you badly for some reason. You are very angry, but you can't say anything back to father. So you go into the room of your younger brother and you start slapping him non-stop. This is displacement. You transfer the emotion from one person to another person. Repression. You forget something and you can't remember it, like that happened in that girl, dissociative amnesia girl. She forgot that the parents died in an accident and now she can't recall it. That memory has been hidden in the unconscious mind. This is called as repression. Rationalization. Giving a logical reason for an unacceptable behavior. Like you ask a person who drinks alcohol daily, why do you drink so much? He says that there is so much of pain in my life that if I don't drink, I would not survive even a single day. He is trying to give a logical reason for his unacceptable behavior. This is rationalization. Reaction formation. Transforming an impulse into its exact opposite behavior. You do exact opposite of what you want to do. For example, say Valentine's Day is coming and you want to go on a date. Forget about going on a date with you. No girl is even ready to talk to you. You are sending messages on Instagram. What are you doing? What are you doing? But everybody is blocking you. So what do? You say Valentine's Day is against Indian culture. And you assemble few friends of yours who are in the same situation. And then you start beating those who are going out onto it on Valentine's Day. So you transform an impulse into its exact opposite behavior. You do exactly opposite of what you wanted to do. Intellectualization. Excessive use of intellect to avoid painful emotions. A doctor was diagnosed with pancreatic cancer. When the surgeon came to meet him, the doctor started talking about the pathophysiology of cancer. What is he doing? To handle the pain of being diagnosed with cancer, he is using an intellectual process to hide that painful emotion. This is intellectualization. Isolation of effect. Isolation of affect. नाम में ये देखो, isolation of affect. Removing the feelings associated with a stressful life event. A mother got to know that she has breast cancer. She comes back home and without showing any emotion, she tells the family members that she has been diagnosed with cancer. This is isolation of affect, removing the emotions from an event. अब ये सारे एक जैसे लगेंगे. Once you revise it, then you will be able to differentiate these. Undoing. An act is done to nullify the previous act. You do something to nullify something that you did earlier. For example, by mistake, if your feet touches a book, you touch a book with feet, you immediately start doing this. The moment you touch a book, you think that the goddess of learning will not forgive you and she will fail you in the exam. and then you do this, and then you think that now she would not be angry and I will pass the exam. Or you by mistake you touch currency and now you think that you will become poor. So then you do this, that now the money will keep coming. So you are undoing. You are doing an act to nullify the previous act. This is undoing. Aim inhibition. You accept partial fulfillment of desire. Like say you wanted to become a doctor always, but you could not pass the pre-medical test. So you become a veterinary doctor. Rather than becoming a doctor of humans, you become a doctor of animals. So partial fulfillment you are okay with. सब कुछ तो नहीं मिला, but doctor तो बनी गए. This is aim inhibition. You bring down the aim. Now we talk about the mature defenses. Sublimation. Transformation of a socially unacceptable impulse into acceptable behavior. So say you are a person who has a lot of unacceptable impulses. You like aggression, you like violence, you like blood, but that is unacceptable. So what you do? You become a surgeon. Now you can play with all the blood and flesh, and it is also socially acceptable. This is sublimation. Anticipation. You prepare in advance for an unpleasant situation. You make a plan. Say you are going back home and you know that your father is going to scold you. So you make a plan that if he says this, I will say this. If he says this, I will give this argument. And still if he says this, I will call the mother. So you go with a plan. This is anticipation. Humor. Use of comedy to deal with unpleasant situation. Use of comedy. Say you go for Viva. In the Viva, the internal and the external examiner humiliate you, insults you, says you bad things. You come out of the Viva room, you look at your friend's face, and both of you start laughing. This is humor. You're using comedy to deal with unpleasant situation that you were insulted. Altruism. Use of a social cause to deal with your own emotions. Use of a social cause. For example, a father was driving a car in a drunk state. A father was driving a car in a drunk state and the car met an accident and the son who was sitting in the passenger seat died. Now father starts a social campaign to tell everyone about the harms of drunk driving. It may appear as if he is doing something socially good, but in reality he is just dealing with his own guilt. This is altruism. And lastly, suppression, which is the only conscious or voluntary defense mechanism. This is something that we use deliberately. So what happens is you loss of a memory which can be easily brought back, which basically means you forget something but you can easily recall it. For example, say you have been studying hard for many days and you are tired. So you tell yourself that for next 24 hours, I will forget that I have any exam and I will relax. So you have forgotten something, but it can be easily brought back. It is there. You have just temporarily forgotten it. Now we talk about the psychosexual stages of development given by Freud. Kriti, yes, sometimes nowadays they don't really ask defense mechanisms much, but they can be asked, right? It's not that they cannot be asked. This is something that they have not asked for quite some time, but because this is mission class, we include it. So psychosexual stages of development, Freud said that the human sexuality develops in stages. And by sexuality, he meant that the way humans derive pleasure, the way human derives pleasure. So Freud said that initially the humans are in oral stage. A child, when he is born, he tries to explore the entire world with his oral cavity. He tries to eat everything. Why? He is trying to explore the world using his mouth. So that is oral stage. Now the child grows up between 1.5 to 3 years. Now he is in anal stage. Now the child wants to become continent. He wants to get control over his body. And that makes him happy that I can control my body. So this goes from 1.5 to 3 years. And fixation at anal stage can cause OCD according to Freud. Why? In anal stage, the child is concerned about toilet training or cleanliness, and in OCD also usually there is issue of cleanliness. So Freud thought that if the development stops at anal stage, it would lead to OCD. Today we know that nothing of this sort exists. OCD is because of corticostriatothalamo-cortical tract. Then the child goes into phallic stage, 3 to 5 years. And the male child develops Oedipus complex. What is Oedipus complex? The male child develops feelings towards the mother. And the male child wants that the mother should belong only to me. But he realizes that there is a big problem, the father. So he decides that I will get the father out of my way. But then he realizes that the father is much bigger and stronger, and father will retaliate by castration, that the father will castrate the child. This is called as castration anxiety. The child is afraid that father will castrate him. How does this complex resolve? The child shifts his affection from mother to some other woman, usually the auntie from the neighborhood who has been picking him a lot, and he makes father as his role model. This is Oedipus complex. The same thing in the female child, where the female child develops feeling towards the father and hostility towards the mother, is called as Electra complex. And finally, it resolves when the female child makes the mother her role model. All of this, nobody can prove it. This is all what Freud said, and sometimes it is asked in the exams. Fixation at phallic stage can cause neurosis according to Freud. So what you have to remember here is 2-3 things in case they ask it. Anal stage, fixation, OCD. Phallic stage, boy, Oedipus complex, girl, Electra complex. This is what they can ask. Then latent stage. Now here what happens? Latent. Now child starts focusing on gaining skills and does not think about sexuality. And finally genital stage, when he develops adult sexual functioning. ठीक है? Miscellaneous topic. Let's talk about ECT first. What is the difference between direct ECT and indirect ECT? Direct ECT and indirect ECT. In indirect or modified ECT, we use anesthesia and we use muscle relaxants. And in direct ECT, neither do we use anesthesia nor do we use muscle relaxant. If they ask you what is the drug of choice, anesthetic drug of choice for indirect ECT, it is methotrexate. And if it is not in the options, then you can use thiopentone or propofol. Muscle relaxant of choice is succinylcholine. And we also give atropine to decrease the secretions. To decrease the secretions. When we were discussing about the Korsakoff syndrome, we talked about the amnesia. We said anterograde amnesia is more common than retrograde, and there only we said that in the ECT side effect, the opposite is true, right? So this has come now. Most common is retrograde amnesia, more common than anterograde amnesia. Some of the other side effects which were usually seen with direct ECT were fractures, because in direct ECT the seizures would happen and could lead to fracture. Nowadays direct ECT is not done, so chances of fracture is almost zero. Similarly, tooth dislocation could happen earlier with seizures. It doesn't happen now. Muscle pain because of seizures would happen. Doesn't happen now. Headache may happen sometime. If the seizure continues for more than 180 seconds, then it is called as prolonged seizure. What is the absolute contraindication to ECT? None. There are no absolute contraindications to ECT. Earlier, raised intracranial tension was the only absolute contraindication. Now even that has been removed. Now even that has been removed. In pregnancy, you can give ECT. Yeah, in pregnancy, you can give ECT. Now we talk about Mental Health Care Act. So Mental Health Care Act is an act which determines the rights of the patients who have mental illnesses and treatment delivery. So there's an important concept of advance directive. So all of us today can on a piece of paper write that if tomorrow I develop a psychiatric illness and I cannot take decisions for myself, this is how I want to be treated and this is what I do not want for treatment. And if I sign it and submit in the government website, it has to be followed tomorrow if I do develop a psychiatric illness. For example, if I write on a piece of paper that if tomorrow I develop schizophrenia, you can give me injectable antipsychotics, but you can't give me ECT. Now imagine 2 years later I develop schizophrenia. My family members show that advance directive to my psychiatrist. He will have to follow it. He can't give me ECT. So that is called as advance directive. I can also nominate a person. I can say if I have a psychiatric illness and I can't take decisions for myself, my wife is the person who will take decisions for me. In that case, my wife becomes the nominated representative. In case I lose the capacity, my wife is going to help take decisions for me. Yeah, it could be for any disorder. There are two types of admissions. Independent admission, which are done by the consent of the patient. Now say somebody has schizophrenia and he can't take a decision for himself. In that case, there is a provision of supported admission done with the consent of nominated representative. The patient cannot give consent, so it is being done with the help of the nominated representative. Duration for supportive admission is 30 days. You can admit a person only for 30 days. You can admit only for 30 days. After that, you will have to take permission from a board. You can't admit the person for years or long months. ECT for minors has been banned. In minors less than 18 years, neither can you give direct ECT nor can you give indirect ECT. If you want to give ECT in minors or if you want to do psychosurgery, then you have to take special permission from a board called as Mental Health Review Board. You cannot do it yourself. A psychiatrist by himself cannot decide that I want to give ECT to minor. It has been banned. Direct ECTs have been banned. Psychosurgery has been banned. Suicide attempt has been decriminalized. Earlier, there was a provision that if somebody attempts suicide and survives, the police could put that person in the jail. Now it is said that if somebody attempts suicide, it will be presumed that he or she is under a lot of stress. You cannot take any action against him or her. So the suicide attempt has been decriminalized. This is all about psychiatry. And not all of you have to fall in love with psychiatry, but everyone should definitely have a little crush on it. All right. So this is it. And now, see, I think a lot of you are using quick revision notes. I think the quick revision notes of psychiatry would be how much? 50 page, 40 page, something of that sort. Okay. Now you have done the class, 30 page, 35 page. Okay. Now that you have done the class, the concepts have been built. And a lot of questions you would be able to do in the exam just on the basis of this concept. Now the quick revision note should be revised by you. And when we go to the lab 2 and lab 3, you would keep on underlining those notes. And when you do the late night PYQs or when you attempt GTs, if you find something new, just add in those notes. ठीक है? अभी नहीं डिलीवर हुए तो जो पीपीटी है वो यूज कर लो. In psychiatry, PPT, quick revision note, mission workbook, everything is completely in sync. हमारे में सब synced है. If you're using mission workbook, it does the same purpose. But remember that you have to underline. Remember, you have to underline. This underlining is going to help you a lot in the last 1 month of preparation. Main notes भी use कर सकते हो. Underline is the thing that will save you a lot of time later on. BTR, you can or you may even skip in this cycle. See, even if you want to just open the BTR notes, everything would already be covered. In fact, कर लो. If you see BTR का notes ना भी, you will feel confident. आप confident feel कर लोगे. But अगर आप अभी नहीं कर सकते, if you want to do it later on, it's okay. You will not miss on anything if you do mission. But if you want to do it, you can do it. It would not take a lot of time. ठीक है? Yeah. क्लास END कल करेंगे. अच्छा, कल END का जो डिस्कशन है, it is from 2 o'clock. Did you get the message? END discussion is from 2 o'clock. Somebody is saying not doing BTR is okay, question mark. I don't think BTR suits me. देखो ऐसा, there would be no resource that would suit everyone. For some people, main notes do not work. For some people, quick revision do not work. For some people, online does not work. For some, offline does not work. For some, BTR does not work. That is okay. Whatever suits you, follow that source, right? So your teaching studying style, whatever suits you, follow it. There is no problem. Don't worry. If you don't like doing BTR, don't do BTR. If you don't like doing online live classes, don't do online live classes. If you don't like mission, don't do mission. If you don't like main videos, don't do main videos. You have to do one thing, follow one thing and continue with it. Tension mat lo. जो सूट करे वो करो. Whatever suits you, do that. Sir, can you upload full class video today itself? नहीं होगा. It takes hours for it to get processed. कल ही होगा. END, you will get 75 questions, 1 minute per question. So you'll have 75 minutes. I think the END would be made live tomorrow in the morning, 8 o'clock. And at 2 o'clock, we'll have discussion. Tomorrow, there are 3 ENDs. एक तो मेरा END है. For batch who is targeting INICT, Goga sir का है. And एक और BTR Zaina ma'am का भी एक END है. तो 3 END हैं. So we have given different slots. चलो. Alright guys. So please revise it. Do the late night PYQ. And tomorrow we have some good question. It's not a very tough test. It is a test, kind of test that usually has questions which come in the exam. I think you would enjoy doing the test. Very few questions are tough. Otherwise you should be good. Please revise properly. Get up in the morning. Do revision first. Then appear for the test. Do the revision first. Then appear for the test. See you tomorrow. All the best, my boys and girls. And may God bless you all. See you tomorrow. Bye-bye. Good night.